أصحاب السعادة, distinguished speakers, ladies and gentlemen, Assalamu alaikum and welcome back to day 2 of the Model of Care Forum. Yesterday we had a rich day full of enriching discussions and insights on the transformation of the model of care. Today will be a continuation in the delivery of these rich insights. Before we start, 2 reminders. One for the CME, just remember to check in and check out for the sessions to make sure you gain the CME for the event. And 2, regarding translation devices, the translation devices work both ways, Arabic to English and English to Arabic, and you will find them on the right side. In our next session, it's going to be a keynote speech that explores the transformative potential of integrating lifestyle modifications into modern healthcare models, with a focus on prevention and holistic health to improve population health and reduce the burden on healthcare systems. Delivering this is a globally recognized leader in healthcare innovation and the chairman of the board at Health Innovation Manchester, with decades of experience shaping healthcare systems, including his role as the former Director General of the UK Department of Health. Please join me in welcoming Professor Mark Britnell. Welcome. Thank you.
Good morning, everybody. I think there's some room at the back for those that want to be seated. I've only got half an hour to talk about the best examples of integrated care globally. So I'll pick on 5 or 6 organizations that I've had the privilege of working with and in over my 36-year career. I would like to thank the Healthcare Holding Company and NASA in particular for inviting me to speak today. For those Saudi nationals in the audience, you will be pleased to know, I hope, that my first visit to Saudi Arabia was back in 2009. So I consider myself at least a veteran for those that come today to witness the tremendous growth of the nation, of the kingdom, and also its health system as well. I'd like to thank Reem, who's sitting in the front, for inviting me. And it's good to see so many colleagues from the United States and the United Kingdom again. And especially, I'm pleased to point out Leslie Thompson, who is the Chief Exec of the accreditation organization in Canada, where I'll be going the week after next. I've been asked to talk about the basis for integrated care. And as you can see, I've had the opportunity to work in many countries around the world over the last 15 years or so. Before I talk about integration itself, I want to just basically summarize one chapter of one of my books. So I will come back to these points at the end, but in the briefing from Joanne and PwC, and thank you PwC for organizing this event, essentially there can be no integrated care without 7 key tenets. And so as I show you in a moment different organizations around the world, you'll see that there's 2 slides for each organization. One on the country, so one on context, and then one on content about what they do that's special to make them stand out in integrated care. But before doing that, in my first book, In Search of the Perfect Health System, there's a chapter dedicated to looking at some of the best organizations in integrated care. And there are 7 things that you should pay attention to. And as you see me go through the presentation, you will notice, and I make no apology for this, you will notice the repetition of certain words. And these words are repeated precisely because they work and they are a quintessential ingredient in the integrated care mix. The first thing I should say is that it's not possible, in my opinion, for any country to have outstanding integrated care without having really good primary care. Now, I told you I've been coming to the Kingdom since 2009. I've had the opportunity to work with the clusters and the holding company and the ministry and the private sector as well with Dr. Suleiman Habib. And I'm not telling you anything you don't know, but unless you turbocharge and strengthen primary care, it will be almost impossible. It will be very difficult for you to actually sustainably deliver integrated care in the clusters. And we know that historically, of course, like many developing countries, the first thing that many countries do is build huge temples, huge hospitals. It's a sign and a symbol of national pride, national power, and also civic need. Now, that's all good and well, but I think one of the major reasons for the clusters in the Kingdom is to slowly but surely and steadily, in a sustainable fashion, start to unpack hospital care because of obviously your long-term condition burden, but also the, I would say, the less than ideal growth of primary care to date. So the first thing to say is, when we talk about the development of clusters in the Kingdom, it would be foolish to concentrate all of our effort, all of our political energy, and all of our resources on making hospitals even better. Really, the biggest foundational pillar that you should and you are building is in primary care. The second thing to say, and it's great to see in the Vision 2030, the interplay between the private sector and the public sector. I have a number of jobs now around the world, but one of my favorite is being a professor at University College London. It's fantastic to see 3 or 4 female students from UCL here today, and I met a couple last night. And the reason why I mention that is, like many countries that used to struggle about you're either public sector or private sector and never the two should meet, this of course is such an old-fashioned form of apartheid, healthcare apartheid, because, and this is the reason why I say this, when you look now at the revolution in data and analytics and artificial intelligence, it's simply not possible for any government, no matter how powerful and rich, like the Kingdom of Saudi Arabia, to actually ever own solely artificial intelligence, data and analytics. And so the future of healthcare, it has been the case for 20 or 30 years, the future of healthcare is undoubtedly plural. And therefore we need people rotating around the public sector, the private sector, perhaps consultancy, but certainly technology. The second thing you will see in the case studies that I'm going to show you in a moment is the primacy of technology helping us master population health. And put simply, technology allows us to slice and dice, to segment and to stratify, and that's the way that we've become much better in managing the third core ingredient of integrated care, which is a strong population health platform. Now, your data systems are emerging. Clearly, there are some great examples of wonderful technology being deployed in the Kingdom already, but consistently the clusters will need an operating model which is based and rooted in a very smart data analytic capability. The fourth thing to say, and this is, I think, pleasing from the work that myself and Steve Field helped the holding company with and the clusters, is models of care. Now, the whole theme of this conference is about models of care, and you have 6 concentric circles, starting with life and ending with death. There are many different models of care around the world. I do think that the progress you're making on models of care is very important. It's important to note 2 things, though. These models of care aren't suspended in a vacuum, and always you need models of care which are being supported and directed by information technology. But the second critical element is that you have control and direction over your workforce, and that includes your doctors, your senior doctors. Now, of course, every health system struggles with this, but the best examples of integrated care in the world is where doctors and clinicians work seamlessly, effortlessly, if you like, if you will, with technology. And that takes me on to workforce. In most countries around the world, the balance of resources between primary and community and acute care is significantly skewed in the wrong direction. Often, a question I ask myself when I go and visit these countries is, it's the show me test. And the show me test is, just tell me roughly, in percentage terms, what percentage of your healthcare revenues are committed to primary, domiciliary, and community care. In most developed countries in the world, that percentage will be less than 22%. Now, I actually don't know what it is for the Kingdom of Saudi Arabia. If anybody knows, please shout out in a moment or two, and I promise you'll get 2 unsigned copies of my books. They're much more valuable. Now, so having said that, obviously the trajectory of the reforms will be to direct resources to primary and community and domiciliary care. And the reason that's important are for 2 reasons. Without a community workforce, it is largely impossible, again, to sustain an integrated care platform. And equally, without having care coordination at the right point, based around the individual patient, it's meaningless. And once again, in a moment, I'll show you different examples where these themes about care coordination around a patient, around a program, and around a population, if you're clear on the taxonomy of reform, if you're clear about which strategy should be applied to which cohort of patients, you have a far greater chance of success. And finally, before I get into the presentation itself, one thing I do admire the Kingdom in doing, and some of you have read my books, I know, because you've had to be my students, sorry about that. But what I like about the reforms in Saudi Arabia, it's highly unusual in developed societies that you get the chance to replan or plan a health system as you would wish to see it. Obviously, most countries in the developed world have legacy systems which are very dominated by hospitals for a whole smorgasbord of reasons. But the 7th and one of the most important factors to sustaining integrated care is by having a supportive policy environment. So what does that mean in practice? It means that your funds flow to where you want the funds to flow. It means you employ more people where you want those people to be employed. It means that your regulation and your accreditation all works in favour of models of care that actually move care into the community. And it also means, of course, that you have a funding settlement which actually enables transformation. In my honest opinion, after 36 years of working in healthcare and the last 15 years of travelling the world, I think what you're doing is stunning. It is truly transformational, and you are seeking to do in 10 years which most countries seek to do yet fail in a quarter of a century. And therefore, my final point before I actually dive into the presentation is, be kind on yourselves. You will make mistakes. I know this is something which is rarely tolerated in Saudi society, but it's okay to innovate. It will be okay to make missteps because you are traveling at a pace that the rest of the world has not seen. Now, I haven't got time to go through. It would be wrong if I tried to summarize the history of Saudi Arabia and the history of the holding company in 2 slides, but that's what I'm about to do. And all of these organizations I've worked in, so I've actually opened the bonnet and I've played around with the carburetor, changed the gear sticks, and enjoyed sitting in the passenger seat. I'm just going to pick 3 or 4 today, just to give you a flavor for some of the strengths. Before I do that, in my first book, In Search of the Perfect Health System, By the way, I'm still searching. But it's important. In the Second World War, the British had a saying, and the saying was, loose lips sink ships. So basically, lack of clarity of thought leads to significant and severe consequences. I often, when I fly around the world and receive tomes, volumes, biblical volumes of information, I say, well, have they actually thought about the problems that they're trying to solve? And the reason why I say that is, and I'm on the board with the King's Fund, the King's Fund did some work a few years ago looking at the taxonomy of integration. And without giving you a lecture today, you can see here that there are different forms of integration. So you can have clinical integration, where you put, say, trauma with orthopedics, or women's and children's services. You can have functional integration, where you merge HR departments, finance departments, IT departments. You can have normative integration, and you can have systemic integration. But the most important part of the integration taxonomy, and this is something I've yet to see in some of the clusters, in the more mature clusters I've seen it, is who are you integrating for and at what level? At the simplest level, a patient with a coordinated care record is a wonderful personification of healthcare integration. You can then think about programs, so think diabetes, think cancer, think maternal and child health, and then finally populations. I know it sounds obvious, but so many organizations get lost in deciding what metaphorical golf club to chip onto the green, in the sense of, is it personal, patient, program, or population? Now, very quickly, in 9 minutes, Montefiore is a really good example of an integrated care organization. It's based in the Bronx, in downtown New York. It's established back in 1884. These are questions to make you think. Montefiore didn't become a fully integrated organization until it did one thing. And what it practiced before it took population risk, before it took capitated payment, population risk, is it integrated its doctors. So essentially, it made sure its doctors were house trained. It got the secondary care doctors to be in a group with primary care doctors, and they worked on their care standards, they worked on their care protocols, and only then, once the doctors, the medics were house trained, if I can use that phrase, did they then decide to take the risk for capitated payments. And this is a very important point, because if your senior clinicians, your doctors, don't think the same, don't work to the same care protocols between primary and secondary care, you have no possibility of ever integrating care sustainably. And as you can see here, I'm not going to read through all of these, you can have these slides. There are certain techniques that are repeated time and time again in the best forms of integrated care. So, for example, why is it that Kaiser spends, I was told by Lawrence Hamilton, one of my friends who's based over in San Francisco, that the initial primary care consultation could take up to 60 to 75 minutes. Now, in England, you're lucky if you get 8, 10 minutes. And why does the doctor, a senior doctor, spend so much time with that patient at the beginning? It's to understand exactly how they see themselves, how they live in their society, and what ails them, both medically, but also socially. And you can see here, in the case of Montefiore, words like one or unified. Montefiore is a very interesting example because in the States it has highly fragmented care. But in terms of health and social care, what Montefiore decided to do was to create one unitary data lighthouse, which took information from local government, from state government, from the municipalities, and from healthcare. And it used that lighthouse to segment and stratify. Geisling, which has now been acquired by Kaiser Permanente, was a health system, first and foremost. It was a provider system. Once again, it's been established for over 100 years. What Geisinger realized, and I think this is what's happening now in Saudi Arabia, is that you can't produce well-being from the four walls of a hospital. You can treat, possibly even cure, but you can't sustain population health. So over 100-year history, and I'm giving you that time frame because that's the journey you're on now with your clusters, Geisinger became a health plan. And then Geisinger suddenly realized that, okay, they were a purchaser and a provider, but what about primary care and community care? And you can see here that being American, of course, they trademarked their most important clinical protocols. Now, I hope at some point in the future, given the global attention now on the kingdom, I hope that you'll think about your intellectual property as you go on this journey. And remember, okay, whether it's the Centre for Value in Healthcare, the learning, the journey is as important as the destination. So please make sure you have some corporate memory. Geisinger produced some stunning results. And this example here that comes from Spain. It's an organisation owned by Bupa originally, which is the British insurer, then sold out to Ribera Salud. They claim, and I think probably they're right, that this is Europe's first ever public-private integrated care organisation. And essentially, in a small place in Valencia in Spain, population only of 400, 500,000, very left-wing government, they were ordered by the federal government to stop spending. They were overspending. And essentially, and I'm just saying this to be playful today, the first thing they did to help integrated care was to privatize and corporatize the leadership of the health system. So the public servants were taken over by the private sector. And of course, what they did, the original contract 26 years ago, was just for the hospital. But the government of Valencia wanted health outcomes to be superior to the rest of Spain. And of course, you can't do that by basing your care just in a hospital. So over time, as you can see by the diagram, and this is quite an interesting evolution, and by the way, I think you're on this evolution as well, is they demanded more risk for more pay. It was the only way they could get to population health. So if people don't think population health or integrated care is the answer, obviously the easiest counter-argument is, so what's your solution? Just spending more in hospitals. And as you can see here, they took on more and more risk as they became more confident. But they also did two other things which most health systems shudder at. They close their eyes and they pretend they can't hear. What they did is they reduced costs by 20%. And this has been independently researched and written up. And also, guess what they did? And now here's the question. Would this work in Saudi Arabia? They put 20% of staff pay on the line so to adhere to clinical standards and protocols. How would that go down in Saudi Arabia? Happy? It wouldn't go down very well in England, but guess what? It worked. Once again, just look at the first 2 points. True care, every patient, they spent time understanding the person who was the patient in order to bend the cost curve over the course of that patient's life. Number two, they standardized all clinical protocols. And number three, they then captured those clinical protocols in a very rich and big and large data and analytics set. And that drove then clinical performance. And it also reported in near real time. And of course, what it did, once you start to publish results transparently, all doctors in clinical teams have to justify their performance. There's one thing I think you need to do sooner rather than later in Saudi Arabia, and that's let the patient's voice be heard more. Publish and be damned. Publish outcomes. Publish experience. Publish safety. Transparency is daylight. Transparency is reform, and reform is better patient care. Now, if I had to pick one country that I've worked in that has analogies with Saudi Arabia, bizarrely, it's Singapore. Now, I had dinner last night with Nasser, and he said he'd been to Singapore. Let's get the differences out of the way. Singapore now is a rapidly aging society. You are a young country. But apart from that, guess what? They have clusters. So each cluster is worth about 2 million. You have 20 clusters, is it? 22? And a population of 40 million, is that right? You say potato, I say potato. Okay, you're working on the same population base. Now, I helped Singapore with these reforms in 2016, and we went to 6 clusters, and they realized almost within a year there were too many clusters. I'm not drawing an analogy here. And then we were brought back in, and we went from 6 to 3 clusters. These clusters are great. Now, you're going to love this slide, and I might run out of time in a moment, but I want you, thanks for coming in now. I'm feeling a lot better. There's more people to talk to. Here's an exam question, okay? Which one word on this slide do you see repeated more than any other word? Who said one? You're all very clever. Congratulations. Now think about this and think about what your clusters are trying to do. Now the difference is you're still trying. Sure, Singapore are still trying, but they're 7 to 10 years ahead of you, okay? Look at this, isn't this cool? And think about your models of care. One community of carers, one network of providers, one set of community health teams, one population, one budget, one menu of programs, and one set of assessment tools. Isn't that wonderful? And of course, they realized, like you realized, one important fact. They realized that hospitals are the most powerful nodal point in any health service because of money, because of politics, because of power, because of tradition, because of the universities. And they realized that the only way they could get hospitals to change is by making them a central point in a new cluster of primary care, community care, domiciliary care, mental health care, and so on, elder care. And essentially, they said to the hospitals, you have to almost disembowel, you have to reimagine yourselves in the clusters. And finally, of course, to get a big, powerful hospital to give way to a cluster of interests to ensure that integrated care is better for chronic disease management and population health, and therefore more cost-effective in the future, your big challenge will be to make sure that people realize integrated care doesn't start in a hospital. It starts with the person and primary care. Thank you very much indeed.
Thank you, Professor Britnell. Our next session is a panel discussion titled From Silos to Synergy, where there will be a focus on uniting healthcare providers with systems to improve access, coordination, and the quality of care in the overall system with a focus on primary care. Now, this is a panel full of experts, both local and international. Moderating this panel is the director of the Oxford Institute of Digital Health, whose groundbreaking research has shaped primary care practices worldwide. Please join me in welcoming Professor Richard Hobbs and the expert panel.
Well, thank you very much for that introduction, and on behalf of the panel, thank you very much for the invitation to speak at Models of Care Conference 2025. I'm delighted to be presenting this session. It's the theme today. Primary care was talked a lot about yesterday, but I think we're spending more time on the meat of why primary care is an essential ingredient in health systems. And I'm delighted to have this panel with representatives from the UK, US, and from the Kingdom to talk through some of the issues that health systems need to consider in relation to primary care. Now, Mark, session just now, I think, was an excellent feeder into this workshop session. Mark said he'd come to the Kingdom, I think, in 2017. In fact, my first visit to the Kingdom was in 1985. And I've grown old whilst the Kingdom has grown young. So I think it's been a fascinating period seeing the changes here and the changes in the UK. So this session is entitled From Silos to Synergy, the Integral Role of Primary Care. I've already been introduced, based as the Director for the Institute of Digital Health at the University of Oxford, and I have been an academic primary care physician my career. So let's go around the panel now and get brief introductions from each of them. Steve, you kick off.
Thank you, Richard. Richard's one of my oldest friends, so he didn't really want to introduce me. So I'm a GP, family physician by trade, but I, in the past, have been the leader, the chairman of the Royal College of GPs in the United Kingdom, the chief inspector at the Care Quality Commission, which is the regulator across England, and more recently a chairman of a couple of hospitals, one of which had an integrated organisation between the hospital, the community and primary care surgeries. So it's wonderful to be here, but the most important thing probably is I was an advisor to Health Holdco and now work for the UK government supporting health in the Kingdom. So thank you for inviting me.
Alberto?
Well, good morning. Thank you very much for having me. It's a true honor and pleasure to be up here and sharing with everyone here and the colleagues. My name is Dr. Alberto J. Sear. I am a board-certified family physician. Formerly vice chair of the Department of Family Medicine at the University of Miami. Currently medical director for the company Cano Health. It is a value-based care 65 and older population throughout the state of Florida. Currently we have over 80 clinics and over 60,000 patients under the care for value-based. During my career, I've been a general practitioner in small towns and in urban areas in the United States. I have managed from point of entry of urgent cares into Medicare Advantage clinics and now coordinating and driving a healthcare system with coordination with value at its core. Thank you.
And Takia?
Yes, thank you, Prof. I'm Dr. Turkir Atabi. I'm consultant family physician. I'm the General Director of the Primary Healthcare Affairs in the Ministry of Health and also the General Director of the Clinical Excellence in the Ministry of Health, the Deputyship of Population Health. It's a pleasure to be here.
And Khalid?
Thank you for having me. Assalamu alaikum and good morning to all. My name is Khalid Al-Mulla. I am currently the CEO of one of the cluster, Al-Hassa Health Cluster. I am board certified family physician by background, and I have been working with the healthcare transformation in Saudi Arabia since 2016 at different capacity. Pleased to be with you today. Thank you.
Well, thank you very much, panel. So let's get into the first question, which I'm actually going to ask each of you to respond to, which is, what does primary care mean to you, and why do you think it's important to the health system? Steve?
So personally, it's been my life, and it means such a lot. That moment where it's quite unique when you're a GP and you're working with a patient or a family, and you're actually so close to them physically and emotionally. It's such a privilege to be a GP, and if you scale that up, the patient is obviously at the center of everything we do. It's at the center of everything you are planning through the model of care. But next to that, it's primary care. Primary care is where you have your first contact with the patient. Unscreened first contact, whether it's with the GP or with a nurse or with a pharmacist. It's where prevention is focused with the patient. It's where you treat the patient. It's where you look after them in their most difficult times in their lives from cradle through to grave. It's where the health system in Saudi Arabia is going, with primary care at the center, and that is absolutely right for all the reasons Mark has just said. So for me, it's the center of everything. It's the center of the future of model of care and of the Saudi health system, and for that reason, you have the opportunity to create the most effective, most supportive, most patient-centered system in the world, and I really envy where you are at the moment.
Thank you. So, Alberto?
Thank you very much. Primary care for me is, I use the analogy of the concrete foundation of a skyscraper. Primary care is that foundation, and the stronger it is, the greater the skyscraper you can build. From a business standpoint, primary care for myself, it is the basis of a downstream revenue for any healthcare system. It's to manage, broker, and coordinate care is what really builds a healthcare system, and that starts with primary care. To me, it is a true dream to see what's happening here, where primary care is truly at the center of the conversation, and the drive to create a healthcare system thoroughly with strong basis, serving a population and creating based on value. To me, this is wonderful, and truly, truly a step into the future anywhere.
So, Takia?
Yes, professionally, I would refer to the Al-Ma'ata Declaration, where it stated back at 1978, where it stated that all health organization, all government, and all around all the world should promote and protect health for all by 2000. So basically, it was also stated that the best approach to do that is through primary health care. So personally, I feel that primary health care would bring us close to our communities. It would provide us with a valuable insight of our community health characteristics, determinants of health. And as a care provider, this would be very helpful, but more importantly, if you are like a decision maker or a stakeholder in health, that would give you a valuable information when to reevaluate your health plans, your long-term health plans for your community. So in addition to that, I believe knowing this information, being close to our communities, being the best hub to implement all the intervention and the initiatives to achieve our transformation goals in Saudi Arabia, the health sector transformation goals. The end results that we want to do is to increase the life expectancy by 80 years in 2030. So not only that, in order to do that, you have to improve the quality of services, the consistency. We have to look at healthcare services from value point of view. How can we contain cost? So it is an established fact that the primary healthcare is the best place or hub to do all of that.
And finally, Khalid.
To me, primary care is the backbone of the healthcare system. It is certainly also an essential component of our transformation in healthcare in Saudi Arabia. And I believe for a primary care provider, it's also a golden moment now to implement all required reform within primary care to achieve the goals. Thank you.
So we've heard quite a lot of description there about advocacy, about population focus, about close to families, first point of contact, continuity of care, public health, advocacy, cost effectiveness in terms of the health system, possibly gatekeeper status. So lots of actions there that actually point out why a primary care community focus is important to an integrated health system. But let's get to the first question, which relates to that challenge of integrated health systems, is where you've got multiple providers, how do you get some levels of standardization? How do you ensure similar health care is provided? So, Alberto, do you want to kick off with that one?
Sure. Sure. So I view that as, based on my experience, two components. One is an operational, one is a clinical. I'll start with the operational. We've discussed common pathways, best practices, utilization and leveraging of the EMR to be able to have safety rails on a pre-selected formulary, that we adhere to the formulary with the decreased cost and best outcomes. Clinical pathways, which through governance are chosen by a committee or a consensus of providers through a leader, and then those best pathways are adhered to, and then of course there's the benchmarking of those pathways based on specific KPIs, which are put in, are linked to specific outcome measures. And then of course, if there's a standard pathway, there's a calculation of a unit cost, and then right there's the formula of value. So operationally, that's one way. And then the other component is clinical, and it has to do with the education. Very clearly, if you have physicians or providers who are put in to work within a value-based care system, for example, and they do not understand the fundamentals of the value-based care system, they don't understand the fundamentals of the economics and how it works and why they have to practice in a way that maybe they're not accustomed to, or maybe their colleagues are not accustomed to. And when they understand the why, you have the buy-in, and thus they adhere to that standardization, and they jump on the bandwagon, so to speak, to be able to understand why they must practice in a way that really is standardized, because it is proven to them through statistics, through the company, or through governance, that those are best practices, and thus standardization, benchmarks on the other end, and time and value, the cost unit based on standardization of the process.
Great. So some sort of preconception here, some models of care actually becomes very important here. But you also mentioned digital, the means to be able to assess the delivery of care through the electronic health record.
Yes, that is correct. A unified healthcare record is essential for standardization.
Yeah.
You have standardization of documentation, standardization of clinical workflows. If you standardize the clinical workflow, the way my interaction with the computer and with the patient, and my time management in the way that I navigate the clinical session, that also helps standardize pathways and protocols. But an EMR is essential. And coordination of care also plays into that, because there are EMRs are very robust, where subspecialist and primary care can be on the same platform. And thus they can communicate. Very robust EMRs, they can communicate. And with that communication comes improvement of coordination and continuity of care.
Yeah, great. So Khalid, do you want to comment on this one?
Well, actually, it is not an easy task to standardize practice among different providers. Yesterday, we heard how in the most advanced, mature system at Mass General, they have 12 radiology protocol in 2 sister hospitals. So in general, this is the healthcare industry and the way it works. In the primary care specifically, I think standardization play a major part, and it will require training, first of all. So you need to standardize the training. You will have providers from different backgrounds, from different medical school, probably from different generations. So that's play a major component. Also, I think each organization need to establish its own guidelines. It's not an easy to implement standardization based on memo or a letter from the regulator. So you need to start your own guidelines and protocols. In our cluster, for example, we established team-based care protocol, and we established it 3 years ago, and we continue to update it regularly. Right now, we are working with the 7th edition, and these protocols being actually reviewed and published by the provider themselves. So it is for them and including their secondary care and tertiary care networks. At the same time, I think there is a great opportunity now at the Kingdom where we have the model of care initiatives. And there are many trainings associated with the model of care initiative. In our cluster, we did almost 800 sessions in the last 3 years for primary care, physician, nursing, and allied health. That's almost 1 session every day for training. And these sessions consist of small workshops, for the provider to learn from. Also, as mentioned, I think having the KPI metrics and pushing those KPI to the practitioner themselves is a key. In our cluster, we have take this further, where we have an award every year for the providers based on these metrics and KPIs, and being published every quarter. And by the end of the year, those providers who score the highest in bringing the standardization and is being shared with everybody. Thank you.
Okay, so something about the system having some performance level metrics. We heard from Mark about 20% of the budget in Valencia relating to some sort of incentives. QOF in the UK incentivized standard care pathways as well. So lots of good tips there about how you can integrate. But I'm going to ask actually a slightly difficult question, really, because let's face it, public perceptions about the value of primary care do vary. And what can we do to tackle that one? And I'm going to kick off with you, Steve.
I think that's right. I think in most health systems, as Mark Britnell quite rightly said earlier on, the first thing countries do are build big hospitals, which are sort of quasi-religious sites that people revere without really knowing what's going on inside them. I think the more people understand the value of primary care, the better it is for the public to understand the value, and especially other doctors, because as I've said before many times, when you're a medical student going through training, the hospital specialists are the ones you usually encounter more than anybody else. And unfortunately, they often, in any country, talk down about primary care and GPs as being sometimes, as I experienced as a student, a lower life form, which is completely unfair. So I think what we've got to do is talk up primary care and talk about the value. We know if value is the quality divided by the cost, there are lots of academic papers that show that if you increase the number of GPs, increase the density of GPs in areas, the quality goes up and the cost goes down. And we also know that in published papers that if you have more GPs, life expectancy goes up, equal to the amount you would get in the same area as stopping smoking or reducing obesity. So we know that more GPs, a primary care focused center for the health center, reduces cost, increases quality. And there was some work, I like to quote the Americans because they're not renowned for universally across the US of having great primary care, but there are some fantastic pockets of it. But in Rhode Island, where they doubled the cost of primary care, the cost of the whole health system reduced. So I think there's an opportunity here in Saudi Arabia to focus on primary care, build it up quickly, improve your clinical outcomes, and reduce the cost to the system. But you need to train more GPs and build up the system now. By doing that, the value of primary care will be clear to the leaders in the country, which it is now to the ministers, to Nasser and his team, but more importantly to clinicians and then the patients. But it's about speaking positively about primary care and demonstrating the benefits, which are really important.
So Khalid, do you want to make a comment from the kingdom in terms of perception?
Well, actually, this is a very common question. We get it. What is the perception of the community toward primary care? And often mislabeled as a stopper sometimes for getting the health care. Yet, if I reverse the question into different context, what primary cares offer the community? And this is what we need to ensure in our system, where we can promote, as mentioned, a value in the primary care, I think the more we understand also from the community needs and the public perception needs, we can promote better value in the primary care. And that's, I think, a key to ensure that the public perception and the public expectation is being met through the primary care network.
And Alberto, do you have a comment from North America?
Sure. So how do you make primary care cool? That's the first question. So primary care has been associated with the underserved population. And that's part of the stigmata behind it. Some population, based on their status, prefer just go to a specialist versus a primary care or GP. And yes, that has to do with public relations, but I do believe that the approach to do it is to cater to the market that you want to provide the service to. And that's just healthcare consumerism. You provide a brand recognition, on-demand service, and our experience in primary care now is a model that's gaining quite a bit of much more gatherers or followers, which is direct primary care. It's a membership-based primary care, and it caters to on-demand, convenient, and like a membership with a physician. And the patient actually has more time with the physician. The visit is not only screening and conversation of health, but it does encompass general wellness. And in the terms of general wellness, there is quite a bit of a market segment. And thus, you cater to a younger population, and you build that incentive for them to continue with primary care throughout their life, but you start young. And you start with late 20s, young executives that want to be healthy. They understand and they have a priority wellness. They have a priority risk aversion. So they want to make sure that they get on-demand care that's personalized to them. And then you leverage at that point technology, wearables, and that part is how you start that. You start the seed early in their late 20s, and then that way they're conditioned to continue with primary care the rest of their lives. And then that's one segment. The second segment would be the older population, 65 and older, which are set in their ways, and that's the cultural shift that's so difficult. At that point, we have that experience with our Medicare Advantage patients to be able for them to adhere to a specific network and not go to wherever they want, for example. That is just hardcore education, setting the expectation from the moment they step a foot into the system, and that way clear expectations leads to good customer satisfaction and adherence to the networks and to the system.
Yeah, so some interesting comments there. I mean, I quite like, Alberto, your suggestion about a rebranding exercise. It's an unusual discipline in relation to primary care having, in some countries, been called GPs, which itself sounds a bit drummed down, or family doctors or internists. So having a variety of terms, I think, suggests that a unifying specialist-led specialty, I think, internationally might help a bit along the way. But let's just turn to another question. I'm going to turn to you, Takia, to talk about the fact that primary care obviously feeds into secondary and tertiary care, and patient flows are back. What can we do to make that transition more effective?
Well, definitely, intersection between the whole or the all level of care system has been there forever, but I think we need to optimize it more. When we think what we need to do in the model of care is that we need that the flow of the patient and the information related to them between all the three levels of care are seamless and organized. So I believe the model of care is the right venue where we can design like a master pathways, system of care master pathway, where all the stop points where you will need to interact with the secondary or the tertiary care to be carefully identified. So our requirement is to have these activities, this intersection between the whole or the three level happens for the right person at the right time, the right information to be captured at the right time. So basically we would need to have this seamless flow. We would want this flow to contain all the standard of care protocols that is known nationally and internationally. We would require a digital support for that. we need all the information to be feasible and accessible by all the level of care. So in order that we can say that we have like a flawless and smooth transfer of care between these levels. And I believe that also we can add a fourth level in the future with the community, with the advancement of the AI models and machine learning and these advancements in technology. I believe also the system will start from within the community with these wearables and the digital twin technologies. The system would recognize those in need. We will be able to do like a risk prediction models. So I believe basically it has to be happening in the right time for the right person, and we will be able, and also we need to have the right information at the right time as well.
So you've talked about some linking physical infrastructure here, which includes digital provision. And in fact, that was going to be the next question I moved on to, because we've heard a lot, obviously, at the Congress so far in relation to digital transformation. So you've already started talking about that, Takia, but let's broaden the question. How will digital transformation of healthcare impact on primary care? Alberto, do you want to kick off?
Yeah, thank you. So in the United States, if you are not, as a community physician with my community clinics, our primary care clinics are linked with the same EMR, but the specialists that we partner with are not. So for us, that's a challenge. I do believe that AI helps tremendously because nowadays we still use the fax system. PDFs that are printed out on their EMR are faxed to us and then scanned in. Right? The fax still lives in the healthcare of the United States. AI can bridge that gap. I do believe that, yes, you have a PDF, but that PDF can be scanned, digitized, labeled, and data structured to be able to obtain information on a dashboard on that patient's care without myself have to going through folders and reading through PDFs endlessly, finding what the cardiologists say, what did the gastroenterologists say. So currently, yes, we can talk about predictive models, we can talk about AI in the future, but right now, that to me is essential because it closes the gap on continuity of care for community doctors or community specialists that work as part of a network of a primary care system, but not within the system itself, and that's one of our hindrances in the United States. Now, of course, if you're within the ecosystem and you're sharing the same EMR, then that's not a problem. But for primary care offices, strictly primary care offices, to work with partners and not not having that specialist within them, AI does help solve that problem. It is a reality today, and it closes that gap. And of course, with good communications comes clear continuity with decreased costs.
Yeah, so that's an important point. I hadn't heard anybody mention fax for a long time, so interesting that they still exist in some of the US. But Takia, do you want to expand a bit on what you were already talking about in terms of wearables and how those could transform data available to the health system?
Yes, sure. In addition to what Dr. Alberto has mentioned, actually, for example, what is happening right now, we have more than 2,000 centers. So we have a lot of disparities between the kind of care that is provided. So advancement in technology had helped us to minimize this disparity as much as we can through clinical decision support system in this unified health records and health information system. And it's also helped us, and this is a fact that is happening right now, to shift from a health system that it is driven by the health-seeking behavior of the attendee in the primary health care to be system generated. So we have like an automated pathways, the model of care pathways for the screening, for the management, for the mother and child care, the mental. It is currently embedded in the health electronic system in the primary health care centers in Raqim system, and it is automated so it can recognize those who are in need to be enrolled in these pathways. So it has helped us in standardization of care, not to have people fall behind our system, and to be automated. This is one. This eventually has helped us also in creating a trusted data source. So we had gaps and difficulties in data, clinical data, for a long time. So having a unified health records, health information system that has the data field that we would require helped us in creating an operating center. So all the metrics related to the access of care, to the waiting time, the appointments availability, the clinical metrics that is really important, that helped us also to update our profile in important organizations such as the WHO. So this is the advancement that helped us really. What we want to do in the future is, as I said before, we are really interested now in recognizing people who are in need at their homes, not after they contact our healthcare system. And this could be through, as I said before, the AI and the digital twin project. So we wanted the wearables and important health data fields to be recognized by the system. So it will nudge those persons and it can start the communication as a representative of healthcare, not waiting for them to attend our healthcare services. So actually, this is an area of revolution, and the innovation are countless regarding this matter.
Yeah, I mean, I think it's, as you've been indicating, it's going to transform a health system to be more anticipatory, less reactive, to plan more things at a population level. I mean, I think the promise of more patient self-management of illness, i.e. reducing the burden on health systems. You mentioned risk identification. I think health systems have got to get better at recognizing the highest risk individuals and intervening early. So all things that really digital transformation is going to be essential for. But I'm going to ask you a difficult question now, because you had careers as primary care physicians and as experts in primary care as doctors. But do you think primary care needs physicians, or do you think that extended role nurses or physician assistants would be sufficient? So, Steve.
Thanks, Richard. So given that the patient is at the center of everything we do and your system does, the patient needs to be empowered to look after their own health, as you quite rightly said. So everything we do needs to be focused on the patient. So high quality information, easily accessible for the patient, guaranteed quality information is really important. And as you know, in the UK, we have 111 across the country where people can access online on their phones through the NHS app or phone for advice. So using that with an element of AI is important. But if you're looking at the primary care team, I think the future will be specialist family physicians, whatever the title, but specialists on a par with specialists in hospitals, with longer training, keeping up to date, with a lot of the care which was in the past in this kingdom done by general practitioners who were just out of medical school with no further training, often being done by advanced nurse practitioners, by perhaps advanced paramedic practitioners, and I like the idea of physician assistants as well, all working as a team with the overarching leadership of the doctor linked to a list of patients. What the kingdom's doing really well is it's pushing hard for all of the population to register with primary care. Once you've got the registered list, you can then use data, electronic medical records, to integrate everything. So you've got a system for payment, you've got a system for quality management. You can then keep an eye on what's happening with nurses looking after patients under guidelines. And nurses and pharmacists are far better than doctors at following guidelines. So you can look at individuals and then you can compare each practice. You can then look at quality. So the future for me is about a primary care team, but with the patient and the family at the center of that team playing a role too.
Okay, let's hear about from the kingdom then. Takir, do you want to comment on this one? Do you think that the primary care team is the future, not just GPs, basically?
Definitely. Actually, in the months of the formation of the model of care, we need to make or implement a coordinated care new roles. For example, the case coordinator or the case manager. We have a major role here in order to coordinate and integrate all the level of care regarding one individual. So we have suggested that we need a case manager or a case coordinator. Their role will be mainly to trace the journey, the whole journey of a beneficiary at our primary healthcare centers. If there's any intervention that has happened to the in the secondary or tertiary care, our main goal is not to lose patient. Even if they need a referral to the secondary or tertiary care, we will need that their primary care physician to know all the health intervention that has happened to them. And this is basically through team-based care approach and through model of care approach. So a case coordinator is really important. As well, we thought of for the maternity pathway or the antenatal pathway, the low pregnancy risk pathway. We think that also midwifery is really important, and midwives can support the physicians. A low-risk pregnancy can be assessed and screened and managed simply by the midwives. So there are a lot of potentials of whom can support the physician in order to make them concentrate on what they really need to do in terms of managing difficult cases, complicated, uncontrolled chronic diseases. So the room is open for different specialities and supportive services within the primary health care.
Thanks very much. Well, we're almost out of time, so I'm going to ask a quick question of Alberto, because I think it's an important topic. And then can you each think about one line takeaway, what you think is the most important point for the audience to take away, which will finish off our session. So Alberto, I'm going to ask you what you think the contribution of primary care is or should be to the public health agenda, with a quick response, please.
Sure. So when you have the first interaction with the patient as their family physician, you are the pathway that captures all the information necessary to establish their demographics, their risk factors, the social determinants of health. And that is the vital point, because that is the first point of entry into the system of the variables that then work into the various algorithms or predictive models, or review the risk of that patient and their complications or prognosis through life of various characteristics. So the entryway, and that is the best. If you have a good pathway from primary care to capture that initial data, then all that data serves not only for public health records, but also to be able to promote policy moving forward based on the data collected, and then, of course, the continuity of the data through time.
Yeah, so I think what we've done in this session is map out really quite a challenging agenda for primary care, because it's much more than just first point of contact. It's this longitudinality, long-term condition management, prediction of risk, community health, but also if you want to operationalize population health, public health in a country, you've got to have that mediated through an effective clinical organization, and primary care is the obvious one. So massive agenda, hence thinking carefully about how you configure it. But in our final 2 minutes, I'm going to go in reverse order and just ask, what's your main take-home point for the audience in terms of primary care? Khalid.
Well, I think primary care is a specialty in its own. And at this era, we are, each health practitioner is practicing its specialty to the max. So in that case, I think primary care workforce need to define their role very clearly when it comes to providing care for patients, utilizing those model of care initiatives as a key element to implement the future of the primary care. At the same time, the other support staff within the primary care, from clinical nursing staff and allied health, are also needed within the primary care, particularly with the era of now with the new technologies. That will bring other challenges within the healthcare system, where we need to ensure that no fragmentation in care and there is good alignment between all care levels.
So integrated and specialist. Takia.
Yes, I believe, I think my takeaway message is just to see primary healthcare as an enabler to our community. So I believe creating a partnership with the community is the major important step that we need to do in the near future. If we look at it from this perspective, we would be going out from the scope of providing a service. So we need to enable people, and we will need to engage with them and make a partnership with them. If we consider ourselves as an enabler, so there will be no limit of the things that we can do. So we need to enable them to own their own health and to participate in that, so the sustainability of this will last forever.
Great. Alberto?
Primary care providers coordinate, manage, and broker the patient's services. They take that risk, but for that we have to empower and provide the operational and institutional support to primary care physicians or primary care providers to be able to drive the healthcare of the patient. And that only can happen with the rebranding of primary care as the empowered speciality to drive healthcare and the basis of it.
And final comment from Steve.
Thanks. In an echo to Mark Britnell's inspirational talk earlier on, I think we're on the cusp here in the kingdom of a system which will become the best system in the world if we get it right. And I say we because I really feel personally very much part of it. If we have primary care at the center of the new Saudi health system, you'll have the best value system in the world, the best quality at a lower cost. All of the academic evidence pushes towards that view. So whilst yesterday we heard that Saudi Arabia has just done the first robotic heart transplant, that might be very sexy, very headline news. What you're really doing in Saudi Arabia is building a health system focused on the patient with primary care at the center, which will really increase the length of lives of people who will now die because of the social determinants of health that they're suffering from the lack of primary care. You will increase the quality of the system. Patients will live longer and happier, and people will thank you more than just the sexy things of robotic heart transplants. So do it properly and do it now. You'll save money and have better quality.
Well, thank you very much, panel, and thank you, audience, for listening to us. And our session is finished. Thank you.
Thank you, Professors Hobbs, Field, Doctors Jasir, Turki Al-Ataibi, Khalid Mullah, for reiterating the importance of keeping primary care at the center of care delivery. We are going into our first break for the day. Please enjoy the coffee and networking, and we will be back to start again and continue the program at 10:40. Thank you.
Welcome, everyone. We have a spotlight session titled Creating Value Through the Model of Care. Our speaker, Dr. Reem Al-Bunyan, is the CEO of the Center of Value in Health. She played a key role in advancing value-based healthcare initiatives that prioritize patient outcomes, provider well-being, and cost efficiency. Please join me in welcoming Dr. Reem Al-Bunyan to the stage.
Assalamu alaikum. I'm truly delighted to be here, part of this program. Many of you know that this is where my own journey started in being involved in the health sector transformation program as a national lead for the chronic disease system of care. Seems like yesterday that we were in a room that's about the size of this room with people from all over the country coming together to design the blueprint for our future models of care. We had people from all over the country, from every part of the health sector, public, private, government. We had patients, relatives of patients, sit and really work hard to design these models with a lot of excitement, passion, and hope and anticipation of writing our future. I'm here today as the CEO of Value in Health. Value in Health is a think tank that focuses on the topic of improving value in health and care. My contribution to the program in the coming few minutes will be to speak about value, how implementing these new models contribute to delivering and realizing a high-value health sector. And I would like to leave you with 3 challenges to focus on for the next part of our journey. So many of you in the room are clinicians or clinical leaders, and maybe I'll ask a question. How many of you are frontline clinicians? Raise your hand. How many of you are in the clusters or provider space? Raise your hand. Okay, majority. How many of you can stand up and tell me what value in health means with confidence and clarity? Clarity maybe is the right word. So let me start with that. Defining what value in health means for us in the national context is an extremely important point of convergence where we all need to come together with a common understanding of what this means. This was the first order of business that we did in our think tank. Value means realizing the best possible outcomes in relation to the resources that we put to realize these outcomes. When we speak about outcomes, we mean outcomes that matter the most. Outcomes that matter the most to people that are receiving the care. We call them beneficiaries because we don't want to assume that they're sick patients. We say they're beneficiaries. And when we say the best possible outcomes that matter the most, we really need to have in mind this shift in our thinking. We always say that this is a paradigm shift, it's a transformation. It's not an improvement exercise that we're doing in our sector. It's a whole shift in our perspective to focus on what's important to the person that's receiving care. What we mean by outcomes is health outcomes, patient-reported metrics like experiences and outcomes, clinical metrics, quality metrics, a whole range of outcome metrics. And when we look the perspective, and this is part of what I'd like to deliver in today's note, the perspective is threefold. The population, because we are a nation that caters to our population. We are a nation that is politically committed to delivering universal health coverage. The reason we have the health cluster design is to cater to populations. That's one perspective. The next ring is the family and immediate community, and in the middle is the individual. Three different perspectives. The same perspectives are in relation to the other half of the value equation, which is resources. All resources that we put to realize those outcomes. Our time, our workforce, hospital beds, medications, carbon. If someone's going to drive a car to go to a facility, if someone's going to have a surgery, everything goes into that part of the equation. So how do models of care link with this? As a frontline clinician, normally on Wednesdays I'm in clinic, but here I'm with you. Where the clinician meets the patient, that is where the magic happens. That is where value is created. That is where the shared decision-making happens, understanding what the outcomes that the beneficiary, the patient, would like to realize, the clinician responding to that. That is where implementing best practice models of care contribute to our national path to realizing a high-value health sector. Now, I'd like to leave you with three important challenges for the next phase: adoption, innovation, and impact. On adoption, I'd like to reflect on what I saw in the exhibition hall. The exhibition hall shows many examples of a lot of work and momentum that's happening. It also reflects that it's very difficult. It's very difficult, and I, was really delighted to hear the panelists over the last day and so speak about how it's very difficult to realize this change, the complexity of our ecosystem, and because we are doing a whole of sector transformation. We're not just changing the models of care, we're changing everything. What I saw also is that the implementation is piecemeal. It's not affecting everything in the same way. I encourage you in the next phase to think about how important it is to deliver for our population the same standard wherever they live in the country, wherever they're going for care. They need to have similar experiences, similar access similar quality. And to realize that, we need a higher degree of adoption and a higher degree of standardization of what we're doing. The next thing, as I say the word standardization, I'd like to take you to innovation. Innovation in the field of health is frankly the biggest challenge that we're facing. We need to respond to this rapid rate of discovery of new drugs, new technologies, new digital solutions, new everything. My own field, I say everything I learned when I actually my residency is already obsolete. We need to respond to that in a way that keeps value in the center of our thinking. Minimize low-value care. Minimize waste. Too many tests, too many things. And think about this, where this entire movement is connected. This was one of the things that, you know, as I put together with the scientific committee, the program for this event, was so important to deliver that the models of care are not separate from this other thing that's called population health, and this other thing that's called service line, and this other thing that's called improvement. It is all one thing that we are trying to achieve, which is the clinical transformation. It's all interlinked. And so as we adopt innovations, or as we consider introducing new modes of therapy or new ideas, consider who or which group of people are the most group of people that would benefit from this intervention. Which segment in terminology, the population health terminology, which segment? Is it people with diabetes, or is it people with severe diabetes? Is it people with type 1 diabetes? People with MS? Which kind? It is an important thing for us to keep in mind, because as we heard, speaker after speaker over the last day and so speak about this being the transformation of the health sector in the world. We are writing the story for others to come and see and share the experiences that we have. Now, last but not least, impact. Impact was the theme of a big workshop that we had last week with His Excellency the Minister. I was frankly thrilled because this event was also renamed to include the word V, or the letter V for value, leadership, innovation, and value. Impact is crucial. Impact is part of the reason, again, back to my own journey, to coming to establishing this think tank on realizing value without measuring, without looking at these metrics and making decisions, we would be just moving things around. We did a project that's called the Paris Project, short for Patient Reported Indicator Survey with the OECD, which looks at patient-reported experiences and outcomes among adults attending primary care. We at Value in Health were the focal point for this project, and many of you in the room, I know, participated. The launch of the flagship report is going to be next month, inshallah, on the 20th of February. And we are so eager to work with everyone to answer the question, now that we have this, now that we did this work, so what? If we don't operate analytically, we wouldn't be changing anything. In addition to measuring and focusing on impact at the patient level or at the micro or the meso level, we really need to, at the macro level, think about measuring the economic impact of all the work that we're doing. Implementing these models of care, we need to carefully look at the true impact on our health sector, whether in parts or as a whole. So my time is up and the screen is flashing, but I would like to end with a very hopeful and excited note to hopefully come back to this stage and read back to you what our views are on the progress, to also showcase what's happening in our country everywhere we go in the world. And encourage you to visit maybe our booth for more information on the Paris project. And with this, I thank you very much.
Our next session is Health Access and Equity, Bridging the Gaps in Care Delivery. Features Dr. Louis Lubon, a Global Managing Principal at Mass General Brigham Global Advisory. With decades of experience in addressing healthcare disparities, Dr. Lubon will share insights of designing inclusive models to serve disease and diverse populations. Please welcome Dr. Louis Lubon.
Assalamu alaikum, everyone. Good morning. Pleasure to be here today. And I would like to take the opportunity to congratulate the Ministry of Health, the Health Holding Company, for hosting this amazing event, Model of Care 2025. Also, the Scientific Committee and the Organizing Committee for allowing me to share with you some of our experiences with health equity and access. So, health equity, we could talk for hours about this topic together. And I am somewhat relieved to now know that I'm presenting to you not as the last session before lunch, but a little bit earlier, so I may get more of your attention than not. Thank you for the opportunity. So, we're going to touch on concepts. We're going to take those concepts and take them to practical approaches to deal with equity. And we're going to take a deeper dive in one of the equity must-dos, which is access and system navigation for our patients, for our families, for their families, and as part of the community. Let's start with vision. Probably sounds very familiar. This is our organizational vision. We talk about integration in our healthcare system. We talk about patient centricity. We talk about creating value. We talk about efficiencies. The strategic priorities, probably somewhat familiar as well. Value, again, efficiencies, research and innovation. And we'll take a little twist on research and innovation in a minute. We talk about revenue diversification. Why? Our margins are so small, if any, that we need to think out of the box on how to potentially maximize the margins that we can create to reinvest in what we believe is the best approach, which is patient care. And then we'll spend most of our time talking about equity, taking a little deeper dive on a practical approach to enhance access for our patients and their families. So to say that we are in societies where equity in healthcare is the norm will not be realistic. I think we'll all agree on that. This is not only applicable to where I live in Boston, in the United States, but it's also applicable globally. Access is deeply, deeply intertwined with equity as disparities in healthcare availability exacerbate inequalities. In addition, we're all facing similar problems. Escalating cost, supply chain, but also overwhelming capacity. Perhaps dealing with patients that present in the wrong setting, with the wrong expectations on the care that they're going to receive, but also labor shortages. And this point, I think, deserves maybe a little bit more than just to say that we are short with a particular discipline or another. Do we believe that we have the right workforce to provide care to our own patient communities? Do they culturally find common ground? Do they have the same upbringing and cultural sensitivities? Perhaps not. But I'll tell you a story about an amazing place in your own country, in the Kingdom of Saudi Arabia, which is Alula. Have any of you been to Alula? I don't see many hands raising. Great. So for those of you that have not been, I highly encourage you to visit one of the most amazing places in your country. But the story that I'm going to share with you is that in a community hospital with an emergency department, the vast majority of the nursing workforce is local. They're members of the community. The connection between that nursing workforce and the patients, not only local, but also transient populations that use that emergency department, is an example to follow. I learned about that connectivity between the workforce and the community by practicing in that emergency department in Alula. I would like to take that home with me in Boston. So congratulations to that staff in that amazing place, again. So these interconnected issues demand urgent attention. The workforce, the overcrowding, the supplies. We're not going to solve that here today, but you will all agree with me that those are imperatives. Now, there are some opportunities out there. Are we grasping those opportunities and acting on them? Just being provocative? Maybe not. Maybe partially. So let's start with patient-centered investments. Is the capital investment that we are undertaking focused on returning value on patient care? I think we should all go through that analysis every time where we're spending our patients and our communities' assets, monies, capital. Is it going to improve a particular, is going to produce an outcome that we are desiring for provision of care? International collaborations, like this forum here. I've learned so much over the past 2 days that I will take with me and implement and share with others. We should do more about finding solutions together. But also, very importantly, healthcare has the right to sit at the table with the rest of the industries that serve the same purpose that we do. We're not here just to obtain a manuscript thanks to a research grant from a pharmaceutical company. We're here to collaborate with them and biotech and others so that we can together produce the gains that we need and reinvest them in the provision of care. I encourage you to think about these opportunities. So what we're trying to do is optimizing our operational effectiveness to reduce cost and unnecessary resource utilization. We're now getting deeper into how we do it as opposed to just conceptually sharing what needs to be done. So we're leveraging the clinical expertise, but we're also integrating the system. And in a minute, you will see the advantages of that integrated system. We want to improve that patient access and navigation because we believe that is a qualifier for equality in healthcare delivery. always looking at our costs and efficiencies, like Dr. Rim mentioned before, but we're also building into the future. We're thinking the next step. How do we leverage this model of care into a model of care 2.0 that perhaps will yield the results that we need? Looking for commercial opportunities that emerge from our research. I just mentioned it. It's just not the manuscript that we get published. Why don't we share the opportunities for that margin generation? And also looking at mission-aligned opportunities that we can undertake. Internally as a system, I am the managing principal for our Global Advisory International brand, which is a mission-aligned opportunity for us to create value and bring it back to the organization. So that integrated system that we start talking about now is becoming real. But it's really up to us to unlock the power. The good news is that this is scalable. This can be done at a single systems healthcare level. It can be done at a national healthcare program, and it can be done at other levels as well. So think about the scalability of this process and the practical approach that we're going to take to access and navigation of our system for our patients. So what does it mean for a patient? Now we're talking about access, that our system is integrated. Our patients in Boston and the region in the Northeast, it means that they are directly connected to the breakthroughs that our researchers produce. So from the bench research to the clinical office where we provide care. Better technology at the fingertips of the patients so they become the leaders in their healthcare journey. I am an emergency medicine physician. I practice. When I evaluate a patient, my initial assessment, I do my intake, I order whatever I think is necessary to clarify a diagnosis, differential diagnosis, and final disposition of the patient. And then I go to see my next patient. By the time I return to that original patient with results, the patient already has the results on their phone. They have Googled what it means, these results on the CAT scan or a lab test that is abnormal. We can have a conversation about what would be the next steps, with me making recommendations and not mandating, with the patient leading the process of those next steps. To some, that may be intimidating. To me, that is liberating. To me, it's finding a partner in the way I deliver care. How do we change the culture that we currently have, perhaps, that we are at the helm of our patients' care, to one where the patient is really on stage and managing that helm? Question for all of you, I think, is the way to go. We have heard this over the past 2 days, how this changing culture in the way practitioners, providers across our healthcare systems need to change the way they think healthcare should be delivered and who is ultimately in charge. An integrated system means that no matter where I go, Dr. Rim, you mentioned this just a minute ago, no matter where this patient comes into the system, in the kingdom, the patient is reassured that the approach to the care, the outcomes, and the patient-centered delivery would be the same, decreasing variability. We aim to provide that kind of service to our patients. making sure that the patient chooses what is convenient for them. If they want to drive to the big academic medical centers, downtown Boston, Tim, you know how difficult to park is in Boston downtown, close to Mass General Hospital. So guess what? Newton Wellesley, which is one of our community hospitals, is much easier. Or Faulkner Hospital, much easier. And they are within the patient's community. So maybe the patients now make a choice on where to go that is more convenient to them. It's up to us to make sure that we provide them the service that they need, and they need higher level of service. The system is responsible to provide the logistics for that support. That is happening today. So we're starting to bring our vision to life. It's tangible. We feel it. I gave you some examples of it. Equity is about access. Believe me, as an emergency physician, I know what this means. I never control my input of patients. Sometimes I can control my throughput. Sometimes. My output, if it requires a next step in the chain, is completely out of my control. I want to change that. I want to be part of the team that looks at the solutions for those multidisciplinary approach to each of those processes. Population health management, another concept. We have heard it over and over and again. We want to start working with our colleagues in population health management to help us identify which are the higher risk populations that we need to focus and create programs for, to produce the highest impact, and then extend it to the whole population. We'll share with you a couple of those very high-risk populations for us. Focusing on outcomes. And when we talk about community outreach, I would like to change the term outreach, because I would like to see our healthcare systems being part of the community. We're not just here and they are there and we are outreaching. We are one. And without understanding that concept, I don't think we're going to have the impact that we strive to achieve. So as a system, we can monitor capacity. We can do this now. Before, we work in silos. Every hospital, every clinic manage its own capacity and its own burden. Today, that no longer is the case. Central access, central transferring system, patients move through the system constantly. That could not have been done without our system being integrated. So we're able to transfer patients between our institutions every day, and it's the norm, not the exception. Patients show up in a community emergency department, but they need higher level of care. They are assessed, stabilized. The system assumes the responsibility of transferring that patient to the higher level of care. Not the patient. The patient doesn't have to drive downtown Boston anymore. They can go to our community hospitals. And vice versa. That patient that requires maybe an appendectomy or a simple, not always, having had one done in May, hip replacement, maybe can be done in the community hospital. There's no need for that tertiary, quaternary academic medical center to invest in resources for those type of cases, perhaps looking at resource allocation in the right way. We're also working in our outpatient settings. Work in progress. We're not there yet. Have to be very transparent with you. But we are making progress in our waiting times for primary care and other services in the outpatient settings. Improving access for the patients in areas that are critical, like behavioral health, addictions, cardiovascular and metabolic diseases. But also, we are helping our provider community by incorporating AI and technology to help them through the process of the patient evaluation, documentation, and other burdens that existed in the past. We heard yesterday how someone had to stay beyond their clinical time to document their notes for hours. There's technology now that can get that done in real time. That's how we change culture. That's how the clinicians understand that there's something for them as well in the game, as opposed to just imposition of concepts. Very, very critical for us are behavioral health and addictions patients. Expanding the access for these patients in the communities has been a major undertaking. We're making some progress here, significant progress. We're deploying behavioral health workers into our primary care settings, into our emergency departments, so they can help us manage those patients that are waiting for inpatient care, as opposed to lingering, awaiting an inpatient bed. We are fast-forwarding their treatment. And some of these patients get discharged from the emergency department if the right conditions and the right outcomes, can be provided. We're also partnering with the communities, and we heard this also in some of the presentations. I think COVID brought some silver lining to all of our practices. For us, it was really understanding that if we didn't become part of the community and invest in the communities that we serve, we were not going to actually achieve our goals, and access would be compromised. So investing in the community means identifying opportunities for community members to train, to provide funding, support, so they can develop the skill sets that are required to serve the community members. Repayment programs with fellowships, with grants, and also establishing behavioral health clinics for our most vulnerable populations, including pediatrics and adolescents. Expanding the access for those with chronic diseases, metabolic, cardiovascular, and for the most needed populations at risk, always evaluating the social determinants of health and getting the support from our population health management programs and initiatives. Other undertakings, United Against Racism, United Against Inequalities, those are part of the core of who we are today and how we connect to the communities that we serve and we're members of. And we take this very seriously. In Boston, excess mortality in Black and Hispanic populations is primarily driven by cardiometabolic disease and substance use disorder. We know this, it's a fact. What are we going to do? We have to act. So acting requires a very systematic approach to produce the results that we desire. Creating structures, first, to identify these populations at risk and how to connect them to the healthcare system, how us connect with them and their communities. Creating processes that actually are supported by the structure that can produce the outcomes that we need. Specifically for these two, but there are many others, particularly patients with chronicities, pediatric populations, and others. And I want to tell you about our success story with our Hospital at Home initiative. Many of you have been practicing, have had these initiatives for years. Europe, many countries in Europe developed the Hospital at Home initiatives a long time ago. In the US, due to the regulatory environment, payer system, this was very difficult to accomplish. We're finally getting there. So probably within the next 3 years, and I'm going to be ambitious, we aspire to admit 10% of our patients at home. 10% of our admissions will be at home. It's a challenge. How are we going to do it? Well, we're doing it already. We're doing it by first identifying the right patients, not only when they come to the emergency room, but also at their homes. When they get admitted, but they're ready to go home and continue their care there. By establishing these multidisciplinary teams and supported with technology, monitor, manage, and heal these patients in their own homes. This is improving access, and it's achieving incredible results. We have started with our medical patients. We're moving to our post-surgical patients, and we are going to start our critical care hospital at home program within the next 6 months. The outcomes actually sometimes are very competitive compared to the inpatient hospital admissions. And we monitor very closely those patients that actually fail the hospital at home and learn from those experiences so we can apply new standards and protocols. So in summary, I've given you a journey in 20 minutes, 25 minutes of our access story. We go back to the strategy and go back to the vision, always focusing on that margin generation that we need to reinvest in the care of our patients. Scalability. We believe this is scalable. This is not unique to one single healthcare system. But there is a process that needs to be followed, and it needs to be part of your strategy workshops. Building a stronger, more resilient core with access, as we have seen. Research and innovation, efficiencies, and potential commercialization of our research productivity. Expense management program, what we call locally in Boston, our active asset management, enterprise asset management. A compendium of disciplines that includes quality, operations, finance, you name it. Meeting all together and from the bottom, from every single site, all the way up to the corporate structure. We have created our own healthcare plan. Who is the largest contingency of customers of that healthcare plan in our system? The employees. There's no better system. Why would I go anywhere else? It's competitive in pricing. I know what is being done. It's a proof record of success there. And new diversified business. I commend you to think about this. There are ways that we can enhance that margin. You have to actively think on them. Always to support the mission, serving the community and being part of the community, most importantly, patient care with research and establishing the next talent for the future. Thank you very much. It's been a pleasure. I've learned a lot, and I hope that some of the points, were motivating to you as well. Thank you.
Our next panel discussion, Population Health Management and the Model of Care. This session explores effective strategies for managing population health and enhancing health outcomes, highlighting best practices and actionable insights to improve outcomes across diverse population. Please welcome our moderator, Dr. Tim Ferriss, and panelists to the stage.
Good morning, everyone, and thank you all for your continued attendance at this wonderful forum. I'm really pleased about the panel we have here, and I know we're going to get some terrific insights into population health. I'm going to start with just a very quick, population health is a interesting concept, as Louis just pointed out. The definitions there are multiple definitions, and I just want to be clear that you all understand what it is we're talking about here. So at a high level, population health is about the organization, finance, and operations that deliver the greatest value in improved outcomes for a population. So that's a very high level view. It incorporates everything, right? But in any one country, population health has turned out to be, how do you fill in the interstices in the delivery of traditional healthcare to make healthcare work for patients across the pieces that aren't otherwise delivered in traditional care? We're going to really focus on that aspect of it. And then I want to say that in several countries, including where I most recently worked in England, population health actually refers to a very specific program, which is population segmentation and focusing on the highest risk patients. That's also called high-risk care management. But I just want to be clear that there are people use these words differently. So let's get started. So I've asked each of our panelists to both introduce themselves and point out and describe one population health intervention that they are particularly excited about. Now, I mentioned one yesterday that I'll just say again because it's such a great example. So when I was here several years ago, I had the privilege to see the virtual hospital program for neonatal ICUs, which has produced fantastic outcomes for the newborn babies in this country. And I wanted to point that out. That is one example of a population health program where centralized resources and technology are used to extend expertise to the far reaches and the most rural parts of this country. That is an extraordinary example of a population health intervention. So I think I'll start with Dr. Abdullah. We're so pleased to have you here, and thank you for being here, and we look forward to your comments.
Thank you, Tim. It's exciting forum, exciting time to discuss and talk about population health. You introduced the population health in wider definitions, and it touches basically all of these aspects. But to me, population health, I can tailor a definition for me as a population health. To me, population health is more of bringing the health care delivery system from the traditional delivery of the curing disease to more of the population-driven community. And actually, it has a major roots back in history where the doctors or care deliveries are more within the population and try to work with the population to better outcomes. So the commonality of the population health is a combination of not only focusing on the disease, but also better outcome, better reach to the segment, better reach to the population. And I can more of normalization, I would say, of the healthcare system within the population. And I think there was a shift or deviation globally that healthcare has become more of separate from the population. And I think one of the major things is how we really work with the partner to touch the population, whether it's a financing aspect or integration aspect or the wider determinants of health. And how can we work with the all the partner or players on the people's health. I will give two examples, which is for me something that we did and something that we are doing it, but we are planning also to expand it. We work with the partner, especially the holdco, the other healthcare delivery system, under the direction of our board and public health authority to reach out to full coverage of a newborn screening for metabolic and inherited diseases. At start, the number used to be 60%. We work with a partner in healthcare delivery system, private sector, government, hospital, and even some of the charitable hospital, just to make sure that each single child, each single baby got the test for newborn screening. In the kingdom, we do 21 diseases for the newborn screen. If you catch it early, it has a major impact in the life expectancy of the population. It has a major impact of the well-being of the family as a nucleus of the community. It has a major impact in the cost saving once you start this newborn screening. And the intervention is not, once you know the metabolic disease, the intervention is not expensive. Actually, maybe changing the milk, giving some hormones, and you have a healthy baby. And you know, we work for a year and we reach up to almost 100% coverage. That's work, actually. We transcend it to other party, other partner, which is how you recruit player, people with you outside the health sector. And I always say that we used to be working in silo as a health sector. So with the Vision 2030, now we are working collaboratively, integrated. So we work with our colleague in the financing ecosystem, and we explain to them the case, and they actually use us as a case for where you get high efficiency spending, where the return of investment and the cost saving exceed the amount of spending. And it gets praised by the finance ecosystem, and we're very proud of that. The other example that I'm really excited, that we have an ambitious goal to reach for the NCD standardized mortality rate to 324 by 2030. And we are working now to touch the NCDs. We are doing it greatly, but also we want to work to augment that, to make sure that we are touching the NCD, which is major killer, or the elephant in the room globally, I would say. We are excited to expand our plan, which is for a massive screening, with the collaboration of the healthcare system. Actually, the mainstay of the delivery system is the healthcare system. We cannot work with them. And I can say that without hesitation, when you work with integration, with the collaboration with partner, 1 + 1 not equal, not 2, actually 1 + 1 with collaboration, it can be 3 and 4 and 5 and much and beyond. Thank you.
Thank you so much. That was terrific. Both great examples, newborn screening and standardized mortality NCDs. And I also really appreciated the way you emphasized the fact that the whole ecosystem has to participate in order for this to be successful, to get from the 60, 70, 80% adherence and rollout to close to 100%. It really takes all players. That is true integration. That also requires data flows, which are critically important. We're going to come back to that. Dr. Ali, how about your pick for population health intervention?
Yeah, thanks very much, Tim. So first of all, I'm a primary care physician, family physician from the UK by background, from Scotland, and have worked many years at the intervention level in your narrower sense with things like hospital at home and multidisciplinary teams. In Saudi Arabia, for the last couple of years, I'm Chief Medical Officer at CNHI, Center for National Health Insurance, which is the peer entity for the system. And so I'm going to talk about population health segmentation, so using data. I think you said data to identify high-risk patients, but actually data to understand the population, understand the needs of the population, understand the disease prevalence, and understand the cost as well, because that's a particular area of gap and that we need to build up. And so CNHI, in partnership with other stakeholders in the health holding company, the Ministry of Health, have developed a population health segmentation model. And this was actually based on the Bridges to Health model from NHS England. And it's essentially a comprehensive data bank. There's something like over 200 million encounters have been pulled into that. 26 million individual patients have been identified through various data sources. And to understand the disease prevalence, so what is the prevalence and incidence of disease, and as well as the cost. And initially, when we developed this model, we were using international benchmark costs, but now we're gradually pulling in more local costs, DRG-based costing, some private sector costing as well. So I think this is really an important tool that helps cluster. If you think about a macro, meso, micro, if you take this tool as a model, at the micro level, it can help particularly providers look at the local needs of their population, enhance care delivery, develop interventions that are appropriate for the needs of that population. For example, one of the clusters in the eastern side noted that sickle cell was particularly prevalent there, where it isn't a problem in other parts of Saudi Arabia. So, of course, the usual suspect like diabetes or other chronic diseases are important. So it allows to really plan and target services. At the meso level, health holding company clusters, you can again plan your activity, manage resources, make sure that there's a focus on things like primary care. And then at the micro level, whether it's Ministry of Health, Waqaya, the Public Health Authority, and of course CNHI as a peer, allows us to really think about health policy. Where do resources get targeted? And what are the outcomes that we want to monitor? What are the outcomes that we want to drive improvement in? For CNHI, we've used this also to link it to the health benefits. So the health benefits is essentially a schedule of benefits on what are the explicit services and that will be provided for the population. And so by understanding the needs of the population, understanding what diseases are important, then we can really have a health benefits package that is appropriate for that need. And then, of course, through time, monitor outcomes related to that as well. So I think this something that we've done is we continue to enhance this. In 2025, CNHI is also developing a risk stratification model, which, again, similar to the segmentation, we've made it available to clusters. It's being used in the Ministry of Health through our colleagues at Lean have developed the Yamama platform, which is based on the same model. And with risk stratification, it will help us go deeper into where is the risk, and then also use technology to help think about what happens with that population and how we drive that risk in the right direction.
It's terrific to hear that description. Thank you. The use of data, the central sourcing as the payer, because the payer has access to all of that data, but to make the data actually improve the lives of patients, you've got to send those analytic reports out to the people who are actually delivering the care. That's a great example of integration. One very quick follow-up. Do you use social determinants of health data in your risk stratification?
Yeah, so we are looking to incorporate social determinants of health, absolutely. So, look, if we talk about we want to improve health outcomes, we want to improve population health, and everybody knows that what happens in a healthcare facility, the 80-20 rule contributes only a small amount to actually the population health. So absolutely, social determinants of health are important. And so from a CNHI perspective, one is understanding what those are. So through registration processes, developing risk profiles for the population, Those include social determinants of health, employment, housing, education levels, income levels. So those are things that we're including, and as we develop the risk stratification, will be included in terms of how do you actually stratify. And then, of course, as we look at outcomes and helping to improve outcomes, what is it as CNHI as a peer would we incentivize? So, of course, things like efficiency of care, improving healthcare, like length of stay and reducing hospital-acquired infection. These are important, and absolutely. But what is it that we can incentivize different that will actually drive population health improvement? So how do we incentivize wellness, community engagement, those type of things that will shift the focus and energy of healthcare providers and leaders in a different direction?
It's great to hear your aspirations for using social determinants of health. I will just say that around the world, people who do population segmentation and risk stratification often don't have access to that kind of data, and that is one advantage of having a national health system is getting access to that data. So good for you. That's a great aspiration. Dr. Woolman, your favorite population health intervention?
Sure. Thank you so much. Again, my name is Bruce Wallman. I'm Associate Medical Director for Kaiser Permanente, one of the largest integrated healthcare systems in the United States. First of all, it's an honor and a pleasure to be here speaking at the conference, and I'm greatly appreciative to the Ministry of Health and all the sponsors for making this wonderful event happen. Now, taking a step back, when I talk about Kaiser Permanente, I like to tell a story. 15 years ago, I moved from Northern California to the Washington, D.C. area, and I needed a mortgage to buy a house, and I went to the bank and talked to the banker, and the banker said, Dr. Woolman, what do you think about the Affordable Care Act, this Obamacare thing? I said, actually, I'm in favor of it. And he says, really? Well, that's interesting. All the doctors I work with hate it. So I had to tell him, well, how to explain this to a non-medical person? So I said, let's say you get advanced cancer, and you need a surgery to deal with it, and the surgeon operated on you and cured you. From your perspective, that surgeon gets paid once. Okay. But what if the surgeon does a suboptimal job and has to operate on you twice? In a traditional American fee-for-service system, that surgeon gets paid twice. So he starts to think, but what if you were a patient in an integrated healthcare delivery system like Kaiser Permanente, where we focus on prevention and screening, and we catch your cancer early enough so you don't need an advanced surgeon? That surgeon doesn't get paid at all. But where would you rather get your care? I'll never forget this story because literally he stands up from the desk and says, excuse me, Dr. Woolman, I'll be right back. I need to talk to benefits at the bank to get Kaiser Permanente on our insurance portfolio. So thinking about how do we do that? And so an example I like to give is our breast cancer screening process. As we know, breast cancer is one of the most common cancers in women and a very important disease. And we have a unified electronic health record. So let's say a woman comes in with an ankle sprain or dry eyes. She sees her orthopedic surgeon or her ophthalmologist. And when she gets to the clinic, what pops up on the screen is this patient is due for her mammogram. So at that point, the ophthalmologist, the eye doctor, the orthopedist, the bone doctor can say, Mrs. Smith, you're due for your mammogram, and book it for her. So she leaves the clinic with both her ankle brace for her ankle pain, or her eye drops for her eyes, and her mammography appointment. And this is very unique in American healthcare because most ophthalmologists or orthopedic surgeons don't really know about breast cancer or wouldn't know the patient is due for it. But in a true integrated healthcare system, they know. And so we have the highest breast cancer screening rate in the United States. And because of that, if you extrapolate the data, about 1,000 women, if the United States screened at the rate we did, 1,000 women a year would survive breast cancer than is seen currently. So we feel it's very important for us, and we do the same for diabetes, blood sugar, and for high blood pressure. And true population healthcare in an integrated healthcare system involves, seeing it at any step in the healthcare delivery.
Bruce, thank you very much. So I don't know, I learned about Kaiser Permanente's program, and we always called it every contact counts. Is that correct?
Exactly right. So even if she's seeing someone, a provider that doesn't have to deal with breast cancer, they know about it, they can act on it, and she can get her screening at any time.
So I would put the hypothesis out that if an integrated delivery system has an every contact counts program, that to me is the definition of integration, because that means that all the preventive services, everything that could help the health of this person is part of their healthcare journey, no matter where they are on the healthcare journey. I think it's a great dipstick for whether or not you've actually achieved integration, is whether or not you have a program like this. So Dr. Camp, it's your turn. Thank you.
So Ben Camp, I'm the Chief Medical Officer of Tanner Health, which is a 5-hospital health system in the southern part of the United States. And I also have the perspective of leading a physician executive forum of 60 of the leading healthcare systems across the country at the Leadership Institute. So the intervention I want to talk about is hospital at home. And it's been mentioned a couple of times, but in its clearest definition, it's the idea that you would take a patient that would meet criteria to have their care given in an inpatient setting in the hospital, and you provide that care at home. It is a concept that is not new, clearly not in the United States. It's been around for over 40 years. And the story goes that a gerontologist looked at a patient and was trying to convince him to come in the hospital, and the patient looked back at him and said, "Doctor, you geniuses at Johns Hopkins are pretty good doctors, but you do not know how to run a hotel," with the idea that patients don't enjoy their stay in the hospital and don't enjoy the rest they get there. So that concept moved along for quite a while, and then during the COVID pandemic, it really started to get a lot of momentum. You found hospitals across the country that started trying to establish their hospital at home programs to varying degrees of success. Personally, we jumped on the bandwagon and started trying to manage our hospital at home program because of overcrowding and some of the challenges that were faced during the pandemic. What we found is that neither our physicians or our patient population were quite ready for it in such a robust fashion as we might have thought. So we pivoted a little bit and started looking at the components of the program that we had. And we moved away from the concept of being hospital at home to more of a hospital to home. The idea there is that you have a patient that may come in the hospital, they'll spend time in an ED observation unit. You have the team members that are able to have conversations with the patient, and then you can get them to home that way. Or on the back end of it, you have a patient that's been in the hospital a few days that might traditionally require a couple more days being in the hospital, but you would let them go home a few days early. These patients at home have remote patient monitoring. They have the ability to monitor their vital signs. They have the ability to do a lot of the laboratory evaluations you may sometimes find in the hospital. They have a technology platform that allows that. And it has been pretty successful overall. Interestingly, because there was a waiver program in the United States from COVID, there was about a 3-year time frame that we're now able to go back and look at the results, because we follow these Medicare patients pretty closely. And what was found, when you look at a hospital at home program, they were able to reduce the total cost of care for those patients who were managed at home versus in the hospital. They were able to reduce some of the hospital-acquired conditions, whether that was falls or infections. There was a slight increase in readmissions, but that's not surprising if you consider that the purpose was to avoid an admission. But overall, it's a successful program. I think there are a lot of the components of this that can be utilized in vast areas of population health from a preventative standpoint all the way to the other continuum.
Ben, thank you very much for that description. Can I follow on from that? You mentioned the lower overall hospital utilization. Was there total costs of care? I imagine the total cost of care went down in addition?
It did. It
did.
sure did.
Yeah, and so that is a theme running through, I'll just go back to Dr. Abdullah here, because you mentioned finance, and you mentioned the importance to your colleagues in finance of the support for programs which themselves cost money and produce savings elsewhere in the system, either elsewhere geographically or elsewhere over time. Can you say a bit more about how you think about population health from the finance perspective?
Yeah, I think it's whether it's a finance or other, actually you need to work with your partner. You need to tell a good story to your colleague just to make sure that you have all the players in the wider determinants of health. If you're going to do a scalable program across the whole nation of Saudi Arabia, you need to have all the players with you in the same page, understanding the purpose or what you are doing clearly, so you could really have their buy-in. And when we do about the financing, it's a pivotal, it's crucial for the sustainability, but they look at it from wider also vision, because they have their own ecosystem where they see the financing searching program will give them a cost saving in the long run. And once we work with them in these tools that they have, and we work together collaboratively, they supported us big time on leveraging such finance of this program, and we are working with them continuously to build this partnership. This is a partnership, feed their goals, because they have their own goals, targets, and also feed our goals. So it's a win-win situation widely. And we do that with also our colleague in education, human resources, and environment. There is a lot of people that we are working together just to make sure that our goals meet their goals, and we reach the middle ground where everyone wins in the very collaborative, integrated way.
It's great to hear. Bruce, you look like you want to say something.
Yeah. I think a key point to consider is it's actually less expensive to treat a patient for early cancer than it is for advanced cancer. And obviously, if the patient has advanced cancer and needs the treatment, we're happy to provide the treatment that the patient needs. But it's in our system, integrated healthcare delivery systems, it's in our best interest to find that cancer early because it's less expensive to treat. And I'm a big believer in the ideal healthcare system is what's best for the system and what's best for the patient are the same thing. And if the patient wants, would want their cancer diagnosed early, and if it's cheaper for the system to diagnose the cancer early, then that's win-win for everybody.
That's great. Dr. Ali, I wanted to ask you, because you, just following up on population segmentation and identifying high-risk patients, actually, it's the literature, the academic literature, it's been difficult to prove the cost-benefit of that approach. There are some studies that have shown it, but there also have been quite a few negative studies published. How do you think about sort of approaching the financing of this program? Does it need to actually save money, or is it just cost beneficial, just like any medication has a cost benefit, rather than actually literally saving money? What is your take on that?
Sure. So first of all, in terms of the transformation within Saudi Arabia, we're all driving towards value-based healthcare, delivering value, improving the quality of care, improving outcomes, but also managing and reducing costs. And so in terms of finances, just to address the financial component, the future state model of funding will change within Saudi Arabia. It's currently a block budget for clusters, and it will change to a capitation-based funding model. And so it takes away, away from fee-for-service. There is still fee-for-service, and they may still continue to be fee-for-service for certain things, but the capitation will be the predominant model, and it will be based on a risk-adjusted capitation. So based on the population needs, based on both the size of the population, the age, the demographics, but then disease burden as well. So I think this changes the dynamics in terms of the drivers from a financial perspective. We see systems around the world that start with a fee-for-service and are trying to develop value-based payment models that support that delivery for value-based healthcare, whereas I think we have the opportunity here to not have that type of model, not start with a model that has perverse incentives and actually go straight to something that has the right approach. And so our focus is, yes, there needs to be more efficiency within the health system. And that is about delivery of more efficient care, improving primary care, strengthening primary care, so what's being delivered, what kind of services are being delivered, but also where are they being delivered, and as Bruce said, how early and how quickly they're being accessed. But then I think some of those efficiencies can be achieved in the short to medium term, but the longer term is really around the influence in the demand for healthcare through improving population health. So if we don't understand the needs of the population, the priority areas, the disease burden, then really we can't target those services accordingly. So I think in the long term, there does need to be that shift towards population health that helps to improve the outcomes. And that's the long-term vision. And that will, the budgets are expected, the finance should slow, but we know that healthcare systems across the world are increasing spending, healthcare costs are increasing, populations are aging. When you get more chronic disease, then there's more spending. So, but how do we actually control that cost curve as well?
So tell me if I have this right. So basically, if you do a risk-adjusted budget for a cluster, then everything that the management team does inside that cluster to lower the costs of care becomes margin for them. They actually,
absolutely, yes.
They actually then can reinvest that money in the population. But unless you provide some sort of cap, there's no incentive to create those efficiencies and work to segment the population and address the specific healthcare needs. Do I have that right?
Yeah, absolutely. So of course, your budget is your budget. There's no necessarily bailout. That's the budget for your population based on risk, and it's adjusted for that risk of that population. And so there's a risk transfer to the providers, to the clusters, to say, okay, we need to manage within this budget. How do we do this most effectively? And then, I think from CNHI's perspective, we would also look at incentives. We may initially try to incentivize how do providers put in place the structures, the capabilities? Do they report data? How do they actually focus on the right interventions that are going to have an impact as well? But ultimately, in the longer term, the incentivization needs to be about outcomes. So yes, then for clusters and the leadership of clusters, how do we deliver care? What's the model of care delivery? Do we just focus on hospitals, or do we strengthen primary care? Do we go out to the community? How do we think about social determinants of health? So these are things that, with that different approach, should come to the surface more prominently and have leaders tackling these things with the aim of influencing population health in the longer term.
That's great. It's tying the financing to the model of care and the delivery mechanism, the theme being integration, right? So Ben, I want to come back to you, and can you, I'm going to shift the conversation a little bit and we'll talk about where we're going. So where is your group going on managing total costs of care for a population, and what are you excited about for the future?
Sure. Well, I think one of the challenges is making sure that you empower the patient. And, when we talk about even the earlier example of hospital at home, a lot of that is putting the patient, making them involved in their overall care. I think that is so important. So what I'm really excited about is the idea to continue that theme across our population using virtual care as a way to really allow those patients to have greater access to their care. especially in regard to some of the more rural areas that we're facing. So I think that is something that's going to be utilized in so many ways across our population.
That's great. I'm reminded of the slide we just saw from Dr. Kandel up here that said equity equals access, right? So, mechanisms for improving access using technology is it's a great example. Thank you. I'm going to go down the row this way. So, Bruce, you're next.
Sure. I think one of the things that sort of I'm most cautious about is it's, you know, patients often see quality as personal experience. And, you know, it's not how smart the doctor is or how good the surgeon was, it's how they felt about the experience. And while that's challenging, I think it's actually an opportunity. So, for instance, in the United States at least, breast cancer is seen as a fearful disease. After a woman gets a mammogram, every night she's worried that she might have breast cancer. We call it a sleepless night. So we said, what can we do to decrease the number of sleepless nights for our female patients? And what we did was, when a woman gets a mammogram, even in a large medical center or a small little clinic, now that it's digital, it's, you know, beamed around the Ethernet, and a radiologist will pick it up, not necessarily in that medical center or even in that state, but pick it up somewhere in the system, and will interpret it. And basically for us, by the time the woman gets back to her car, half an hour later, her phone goes off, her final result is there. So before she gets home, she knows the result of her screening mammogram. And given that 80% of the mammograms are negative, 80% of the time, that woman will have 0 sleepless nights if she's concerned about breast cancer. And it's hard to get lower than 0. And so we're very happy with how that worked out.
Bruce, that's a great example of patient-centered care and really making sure the technology infrastructure that you've got is serving the need of the patient. And I love the way you framed that as something measurable, which is sleepless nights, right? And I'll just say a personal experience from my family, knowing that with my wife, we've had lots of sleepless nights because of waiting for her test results. So now it's time for me to get healthcare at Kaiser Permanente, right?
You're welcome anytime.
Yeah, okay. Dr. Ali, what is a concern and what is your hope for the future?
So hope for the future, I think, you know, what we see in Saudi Arabia is there's opportunity. So there's lots of ambition, lots of will to do things, lots of ideas and different approaches. And so I think, and particularly that focus on population health, you know, this is, I think that's really an, so and for me personally, that's an exciting opportunity. In terms of what am I concerned, I would say, I think sometimes we can underestimate the power of collaboration and sharing learning. So I think the more we can do of collaborating, whether that's international, but within the country, that requires alignment with stakeholders, clarity on roles and responsibilities, working together, and sharing learning will accelerate the pace of progress as well. I think sometimes we underestimate it, and the more of that we can do, the better.
That's great, and this forum is a terrific example of an opportunity to share. So thank you. So, Dr. Abdullah, last word, concerns, and what are you looking forward to?
So I'm an optimistic guy, so I would say I would start by what I'm excited for. We are in the biggest health transformation, I think, in the globe. And the good thing that we have a clear vision and we have a great direction. I'm not worried that we will reach our direction and our goal. We may face delay here and there. We may reach our goal, but we need some optimization, and that may take time. For that, I'm not worried. I'm excited. We have a passionate leader, passionate healthcare worker, passionate system, and passionate collaborator that they put the patient on front of everything. What's worried me, actually, if you look at in the longer duration or longer period, is the center of that all care, which is the people or the person. We are living in a very connected world, and the misinformation, miscommunication, and the somehow devilization of the health, it may be a concern. We see it in the vaccination. We see it in the vaccination hesitancy. We are not unique. We are not isolated from the world. We are a part of the world that they listen and hear about the. What worry me that maybe we'll face an issue where we do have this mechanism, but the patient or the person, he refuses for various reasons, get benefit of the prevention of this delivery. Maybe they not go to have this mammogram later on because he believes that there's something, or maybe seek traditional medication for the sake that he will cure. And we have figures that they may give this information. So that worried me in terms of implementation of that. Thank you.
I'm so glad you raised that. It's such an important point that the source of information and what that information has exploded, the number of options that everyone in the world has for consuming information, and the relative accuracy or inaccuracy of that information is a completely different world to 20 years ago. And this is new territory for all of us. It particularly is relevant in areas such as vaccine hesitancy. Certainly in the United States, as you well know, I think you were referring to, that is a major issue. Let me just, I wish I could say I had some resolution to that. We're going to have to work hard to overcome information inaccuracies. But having said that, what I sensed from this group was a real sense of optimism about the opportunities to use data in an integrated system to make sure that all parts of the system are aligned around what is optimized for the patient's care, both in prevention and treatment of illness and conditions. I think it's been a terrific group. Please join me in thanking them for their participation.
Now we're going to take a lunch break, and we're very excited to continue the discussion with Dr. Mahmoud Khan at 1 p.m. Thank you for your engagement and attention. Welcome back to afternoon sessions. Our next session, Transforming Longevity Lifespan to Health Span, it will be delivered by Dr. Mahmoud Khan, the CEO of Evolution Foundation. Today, he will share insights into interplay between integrated care and scientific advancement aimed at improving quality of life. Please welcome Dr. Mahmoud Khan.
Assalamu alaikum. It's good to be here. Good afternoon. What a pleasure. My first time attending this conference. I know this is the second one. And the topic I want to touch on is something that is directly linked to this whole conversation that I know that's been going on here, which is how do we transition from sick care to health care? And if we're going to address health span, which I'll talk about, it is not possible unless we start to think about aging as a process which can be implemented and addressed relatively early in one's life. Now, we've known this as physicians. I know a number of you, I'm an endocrinologist originally, and as a clinician scientist and many, many years of practice, I know that the majority of the time we spend in our resources are very much because we're occupied in taking care of patients. And the challenge for healthcare systems is how do we transition from putting the resources which are necessary today to investing some of our resources as to what the future might look like. And I'm the first to acknowledge that what we at Hevolution do is looking 5 years, 10 years out from now as to what is the possibility of what the future looks like. The first question I want to touch on, though, is why do we need to change? What are the imperatives that are pushing us to think about this? And I want to start off that Hevolution is not focused on longevity. And I'll explain why. We are not about lifespan. We are very much about health span. And let me explain that. Health span is the part of your life when you remain healthy, functional, and independent. Lifespan is how long you live. And unfortunately, the two often get confused. We have done surveys, research around the world, and the vast, vast majority of people, regardless of culture that you ask, will tell you they don't want to live longer just for the sake of living longer, sitting in a bed, being dependent on relatives, being dependent on society. They want to remain functionally independent, physically, mentally, and often actually also financially independent so that they can contribute to their communities and their families. And that's why it's important for us to distinguish between the two. Having said that, there is an interesting, consistent pattern around the world. On the left, you look at the different WHO regions that are shown here, starting globally, all the way down to Africa. And on average, life expectancy is about 73 years globally. Saudi Arabia is slightly better at 74. And if you look across, life expectancy highest around 78 in Europe. If you look at health span, it of course varies across the world, somewhere in the 60s and high 60s in the Western Pacific, of course Japan, the lowest being in Africa, but one thing is consistent. No matter where you look, on average, humans spend about 10 years of their life with some significant illness at the end of their life. That 10 years of morbidity is actually when 80 to 90% of healthcare delivery resources are targeted. In the United States, the vast majority of our resources are literally spent in the last 12 months of life and the first 12 months of life. And so, given this is not just a public health initiative, this actually is of big importance and has a lot of attention now from ministers of finance. Because it is the ministers of finance that are funding the care of that decade. And this is particularly acute in selected parts of the world that I will touch on. If we look at the population demographics around the world, you will see there on the horizontal the size of the population and the vertical the age, and you can see across the years, starting in the 1950s in the middle, all the way projected now to the end of this decade and this century, at the year 2100, the world's population is aging. There's no question about that. We continue to see demographic change across the world, including in South Asia and Africa. What is not shown on this number is that while the population is aging, it is actually not growing in absolute numbers in the same way. In fact, the WHO now projects that the world's population is now stabilized somewhere between 8 to 9 billion. As a result, we're not going to have more people, we're just going to have older people. Currently, there are about 1 billion people on the planet over the age of 60. The projection is by the year 2050 to 2100, there will be 2 billion. Imagine a doubling of the world's population of people over the age of 60 in our current healthcare systems and our current healthcare models. If we have 1 billion more people, over the age of 60 on the world to take care of, how do we take care of that population? And I'll come to the kingdom in a minute, because we often think that this is not a challenge for GCC since, quote, we have such a young population. That is true. However, we need to look at what the projections show. Why is aging such an important issue for health providers? It's shown on the left graph here. If you look at the relative incidence of a disease, and I'm showing 4 diseases here against age, cardiovascular disease, dementia, cancer, and diabetes, not surprising to any clinician, age is the single largest risk factor of an individual actually being diagnosed with any of these chronic diseases. Takes off somewhere around the late 30s, and by the time we hit the 60s, in particular for diseases like dementia, it's really an exponential increase. Now, look at those numbers, because if you look at the GCC countries, we're on the left end of that spectrum. Yes, we're seeing diabetes taking off, but the other diseases as a population impact are literally only a decade away. And so as we start to think of our healthcare delivery models, it raises the question, are we prepared for this tsunami that's coming? It is coming. Now, what we have also seen, that the impact is different in the Gulf than it has been seen in Northern Europe and in North America, and I'll come to that in a minute. Let's look at the graph on the right. This is what finance ministers are seeing. Doesn't matter which country. On the bottom there are healthcare expenditures per capita. On the vertical is the outcome, quality of life impacted. One thing is clear. Once you move past about $3,000 per capita, you can go on and continue to triple that investment. Actually has very little effect in ROI. This is what financiers are seeing. In terms of a business ROI, if you were a business person, you would be tripling your budget and seeing very little in return. Almost no change in return. So understandably, financiers, private and public and government, are asking health systems, if this is the state, then why is it that we keep raising the budget, but we're not seeing a return? This is particularly true as the population demographic changes, as we start to see that aging of a population. So first, if you're really going to make a difference in life expectancy, you have to start early, most of it in children, young adults, and then carry that preventive public health initiative across. That is not on the right end of this curve. Unfortunately, if you look at that one dot on its own all the way to the right at the top, that's the United States. As you cut to the left, as you cut across, including in the Gulf, a number of wealthy countries are in there, and we're asking this question: what are we not doing that needs to change this trajectory? And this is real world data. Now, every region in the world is getting older. I'm not going to dwell on that. Doesn't matter where you look, it is getting older. At the bottom, you'll see in 1990, the median age of a Saudi citizen was 18 years old. Today, the median age is 30. By the year 2050, it will be 40. Our population in the kingdom will have aged another decade. Remember that graph I showed you of disease risk? Let's take a look at it again. The one on the left, our population has been all the way to the left of that. It is now between that 35 to 40. It will be hitting the 40s, and look what's going to happen to the prevalence and the diagnosis rate of these expensive to take care of, significant morbidity diseases. So that's what's coming. Given that, we start to ask ourselves, what is happening across the GCC? On the right there, you can see the GCC countries, the UAE, Kuwait, Qatar, Bahrain, Oman, and Saudi Arabia. The percentage of the population shown on the vertical, which is age 65 or over, hit a bottom somewhere around 15 years ago. For the last 15 years, a percentage of our population of 65-year-olds has continued to go up. It will now rapidly rise. The population demographics are being changed by the simple fact that our birth rate in the kingdom and in the Gulf has gone from around 6 children per couple down to about 2.2. 2.17 is the replacement rate of a population. Every couple needs to have, on average, 2.17 children just to replace the population. We're just hitting that, which means every person dying is being replaced by one child. The population is not going to grow, it is going to age in place, and if our birth rate continues to decline further, as it has happened in Europe, as it has happened in the Far East, once it dips below 2, the population actually starts to decline. This has been seen in Japan, it's been seen in South Korea, it's been seen in Scandinavia, Italy, etc. Across Europe, we've already seen this. This raises questions not only for healthcare, but population, labor force, social security, all of the things that we are now taking for norm in a pay-forward society are going to be challenged. Now, we looked, you know this data better than I know it. The percentage of population of adults, 40% of our males are obese, 78% of our females are obese. This is the current data, which means our risk of age-related diseases, metabolic, and obesity-related tumors, colon cancer, breast cancer, is occurring on average 5 to 10 years younger in our population than it's occurring in Western Europe and North America. So our population is going to age fast because of demographic change and biologically age faster than we've seen it in the past. So this is what this meeting is about. Our healthcare system has been about patients are well, they get a chronic disease, and we treat them. What we're talking about is how do you shift to that preventive model so people can age in place in a healthy manner. I'm not here to talk about exercise, keep your diet, stop smoking, sleep well, low stress. We know all that works. The challenge we've had is implementing it. As an endocrinologist, we were talking to patients about obesity and their diet for years. Very little impact. And then we understood the biology of the therapeutics, and suddenly the epidemic of obesity starts to change. Now, I'm not suggesting that everybody in the country starts taking GLP-1 agonists, far from it. But it tells us that what we have been doing versus what the future is versus what is being accepted by our patients is changing. They're asking about aging. We did a survey of clinicians. 50% of them have been asked as physicians, what can I do to stay healthy and age well? Consumers and our patients are now getting more and more informed. So let me have what is Hevolution. Hevolution was created by royal order, signed by the king back in 2018. We are the second nonprofit created in the kingdom in 70 years by royal order. Our mission is to expand healthy lifespan for the benefit of all. And that is to fund the science in a number of ways, by providing research funding, by providing investments, creating companies, both in biotechnology, therapeutics, and diagnostics, to understand the bioethics of all of this. I'll give you the last 3 years of work, basically by a lot of young people. I have the privilege of providing some coaching and guiding to, headquartered in Riyadh, with the first global organization in healthcare of our nature ever created out of the Middle East. We operate across the world, and I'm going to show you some of our reach and our impact in a minute. We touch the entire value chain of healthcare. We talk to consumers through our media and communications initiatives. We think about the legal and ethics of healthy aging. We think about medical, both from a regulatory point of view, policy point of view. We provide research funding and grants, investments to create companies and fund companies, think about drug repurposing, using existing drugs, and ultimately validating and studying how to create translational centers that ultimately would end up in your practice centers. That's how we think of ourselves. What have we done? Let me talk about funding. Today, Hevolution has committed over $400 million to this field. We are the second largest funder of aging biology and neuroscience in the world. We're second to the US federal government. There is no other philanthropy or agency bigger than ours in terms of our footprint. Very few people in Saudi Arabia actually realize that. And it's a matter of pride for us that we're actually leading the world. Anytime you're number 2 to the US federal government, that's a pretty good position to be in, given they've been doing this for 70 years. The second is that we have now currently funding 230 grants in over 200 laboratories around the world, including in the kingdom. Our first 12 Saudi scientists were funded last year. Our next 14 are due to be informed that they've received their grants next week. And for those of you who are my friends, I've been privately share that with you. What is good and delightful for me is those Saudi scientists that have been recognized for their funding. We fund the top 10% of all global applications based on the scientific merit. Last year, we funded a scientist at Taif. We funded a scientist in Jizan. And of course, all the usual that you would expect, King Faisal, KMARC, KSU. Yes, those you would expect, but we're getting some wonderful ideas from around the kingdom that, and I wish I could tell you this year's, but they include several from outside Riyadh. So these are now being brought in. The other thing we're going to announce next week, and the recipients are the first 4 Saudi postdoctoral students, MDs or PhDs, are going to be sent from the kingdom to any one of our funded labs around the world to train as geroscientists. Not to train in geriatrics, but to train in the science of the biology of aging, so they're the ones who become the entrepreneurs of the future, the investigators of the future. Today, we have partnerships with institutions like the National Academy of Medicine, the Buck Institute, Albert Einstein, Northwestern, National University of Singapore. I can go on, but already we have 25 partnerships, including several in the kingdom. This is where the science is being promoted and developed. Let me leave you with our operating model. Everything we do at Hevolution is partnerships. We're a small team. We're about 90 people. Most of us are in Riyadh. 70% of my team are Saudi. 40% of my team are women. And 4 of my executives who directly report to me are women. So we are representative of the ecosystem in a way that I would actually be proud to represent in any Western institution. I would challenge most Western corporations in terms of direct reports of the CEO and the executive team, 40% are female. So we truly are representing the future of this country and the future of this field around the world. We think about impact, but we recognize you're not going to have impact without collaboration. If you do figure out how to collaborate, that gives you leverage, and ultimately it is leverage that gives you the scale. And that's exactly how we operate. And so, if I leave you with the thought that we believe only together can we overcome the greatest challenge facing humanity. If you actually think about the population change, the healthcare costs, the GDP impact, let me give you a number that if you want to look at the reference, look in the journal Nature. A Harvard team and an Oxford team analyzed the GDP impact. If we can compress out of the last 10 years of our life, just by 12 months, a period of illness, just reduce it by 12 months, the GDP impact in the United States alone will be $4 trillion. 4 trillion. If we now include Europe across the world, we are talking $20 to $40 trillion of GDP impact if we can crack this. Even if the economists are wrong by 90%, that is still a $400 billion to $4 trillion GDP impact. So I ask this, when I talk to finance executives, when I talk to ministers of finance around the world, or prime ministers around the world, and they ask me, why is research so expensive? My response is, if you think research is expensive, try disease. The cost of this healthcare burden, the demographic change, is a log scale greater than the cost of investing in helping keep this population healthy as they age in place. That is our mission. That is what we do. And we truly are proud of the fact that we are one of the top 2 organizations in the world leading it right from here in Riyadh. Thank you very much for your attention.
The art of chronic disease management. Our expert will share insights on patient-centric approaches, effective strategies for managing chronic conditions, and the last advancements in the field, exploring how to empower patients in their care and provide actionable advice. Please join me in welcoming a moderator, Prof. Mark Britnell, and panelists, and a gentle reminder, there will be at 7 p.m. a closing ceremony in the presence of His Excellency, the Minister of Health.
Well, good afternoon, everybody. That was a fantastic presentation, and I'm sure you all agree. The previous speaker made a great play about saying he had 40% female representation at the top levels of his organization. We can do better than that. We're going 50% today for this panel. I think this panel brings a lot of this morning's learning together, and we have 4 distinguished practitioners and policymakers that are going to talk about chronic disease management. I always think it's best when we have a panel such as this that the panelists introduce themselves, therefore you can understand what they think is important about themselves. And we've asked the panelists to speak for 8 minutes or so on 3 questions. Now, they don't directly have to address these questions head on, but it won't surprise you to know the 3 questions are, what are the most effective strategies for combating chronic disease? How can patients be better involved? And what are the latest advancements that we see both in the kingdom and abroad across the world in combating chronic disease? So without further ado, please.
Thank you so much. This is Tagreed Al-Ghait, and I'm the Chief Officer of Health Improvement and Promotion in Public Health Authority. And in terms of background, I'm a health policy expert. Thank you.
Good evening, everyone. This is Fatma Al-Slail, the Director of the National Diabetes Prevention and Control Program and the Director of the Cardiovascular Program at the Ministry of Health, and a WHO member with the Advisory Group on Diabetes. And my background is I'm a public health preventive medicine physician. Thank you.
بسم الله الرحمن الرحيم. السلام عليكم جميعا. مساكم الله بالخير. مشبب العسيري, oncologist, Director of National Cancer Center and Saudi Health Council, and oncologist for the last 30 years.
My name is Murad Salam. I'm a vascular surgeon and the clinical lead and head of service for vascular surgery at Guy's and St. Thomas's, London, and undergraduate education lead for cardiovascular. I do work in the transformation in the trust, and I advise the trust for international partnerships and collaborations.
Well, thank you for those introductions. Please tell us about your experience in the kingdom and your perspective.
About NCDs, right? Yeah, so I'd like to really refer back to it, the talk that we have heard this morning about, creating, avoiding silos and going into synergies, and which, left me thinking of, a very important work that we are, working on currently in the Public Health Authority, and, where we are trying to bring all the sectors together and really to promote a multi-sectorial approach towards implementing our initiatives. When it comes, you know, to the model of care and how is it related, you know, to the work that we're doing, model of care is a very important channel for us in the Public Health Authority in order to make sure that our interventions are penetrating the model and are actually being delivered. So this is in general, you know, what we're doing in the Public Health Authority. Specifically, we have worked during the last year and, you know, in terms of designing, I'm sure that, you know, most of our colleagues attending, you know, this forum have heard about, you know, the 90-90-90 approach. And the 90-90 approach, it's a methodology that is being developed by the data team in the Public Health Authority, and it helped us tremendously in identifying what are the chronic diseases that we need the model of care and the pathways to focus on and direct our resources to it. The most, you know, chronic diseases that we need to apply the 90-90 approach on are the diabetes, hypertension, and the smoking. These three diseases are the driving diseases for the mortality that is, you know, caused by NCDs. So basically, you know, this is, you know, our aspiration and our goal in the Public Health Authority is to have the model of care really delivers what we, you know, in the Public Health Authority in terms of prevention from the NCDs to focus on. Thank you.
Well, thank you for those introductory remarks. Could we go to the United Kingdom now, and perhaps you can give us your view?
Yeah, so first of all, it's a bit of a pressure and a pleasure to be a surgeon in this panel with lots of experts in chronic disease management. But I will try to tackle the three questions as you've put them, Mark. And the first one about strategy, thinking of prevention, early detection, and management. And a couple of points on each one of them that could feed into a comprehensive strategy. And I guess there are so many messages that are coming over and over today from the different talks and panel discussions, and that's because they are important, but they are also very difficult to implement. So I would go in the prevention and say two things that we've heard earlier today. One of them is the lifestyle and the standard approach to improving lifestyle, from nutrition to general health habits, exercise, and good sleep, and all of what we've heard. I think this is a key point. But again, it's not about knowing what it is. It's about how you can implement that, how you can really improve these lifestyle changes that will prevent or delay a start of a chronic illness. And I think the focus on the strategy is how it will be implemented rather than the content itself. And the second thing is there are some new potentially gene therapies that are going to come to play into intervention at some point in the prevention side of knowing patients that are of high risk profile or with strong family histories. There would be some interventions coming through research that could impact that at a stage of a prevention rather than early detection. So I would say these are the two highlights on the prevention level. Going on to early detection, and I think early detection only work by strong and empowered primary health care. And the strong empowered primary health care will be able to put a surveillance program, awareness campaign, work on the health literacy, which I'm going to touch on in a bit of more depth later. And I think a good, strong primary health care would really be very helpful on the early detection side of things. There's also the use of technology and data and all of the informatics. If you have good quality data, you can use AI into predictors of high-risk groups, and you can focus your screening programs on those ones based on their profiles. And I think that's going to make it more cost-effective, potentially more convincing to the population. Why am I having this screening? Well, you fit the risk profile. And that is for the early detection. And I think that's on the shoulder of mainly primary health care, but empowered by the whole ecosystem. And then we go to the management, and I think the management of chronic disease, two things I want to allude to that are less talked about. One of them is developing pathway that manages multiple comorbidities or chronic diseases when they overlap. And the whole pathway is designed around combinations that are fixed. And I say that with my hat as a vascular surgeon, where 80% of my patients walk through the door at least with two comorbidities, if not more, and they've had it for years and years. So we need to have a think about designing pathways that are for lifelong comorbidities and combinations of that, and not leave the patient scattered between who's dealing with the diabetes, who's dealing with hypertension, who's dealing with so and so. If there are combinations and links, there need to be pathways with that. And in fact, the geriatric medicine in the UK has really pushed that forward, where they can bring together things related to multiple comorbidities, but also the concept of frailty. And I know it is not one that is widely spoken about. And I'm going to do, if you allow me, Mark, to do the exact literal translation. So the literal translation of frailty, and it's now a syndrome, is al-wahn, which means the functional decline in addition to the lack of reserve. That's kind of the simplest discussion, the simplest definition for that. So understand, having pathways that tackle this, understanding a bit more of managing frailty and putting it in context of assessment of the patients when they have major surgery, when they get to hospital, when they get out, is an integral part of the management. And then the second one is the quality of life, and we had a fantastic talk about the health span, which I really liked. I liked the word, and I liked also the principle in general, and focusing more on good living with the management of chronic illness, not just surviving. So if I would summarize this part of that question, I would say the classic slogan of we want to see less and pick it early and navigate it better. That's from a strategy main principle. Moving on to the empowerment of patients and making the patients more involved. And two sides of this that I want to touch on. One is the patient literacy, the health literacy. And I don't know if you'll be surprised or not, but even in the UK surveys, recent surveys, health literacy is less than what you would expect. And I think as healthcare professionals, maybe for years, we've failed to move on from focusing on the content to how it is delivered and how to make it relevant to the patient. So the health literacy is, and in my view, we need probably to involve sociologists, anthropologists, and educationalists to really design with us the health literacy programs. We think if doctors give the content and we have a nice design of, oh, well, we'll put pamphlets, we'll send messages, that's it. I think there is more to that. They need to understand the society. They need to understand what patients would like to know and how. And I think health literacy needs really a very strong panel of people who are sociologists, anthropologists, educationalists, plus, of course, healthcare professionals. The second thing is content, access to the content, and the reinforcement of the message. The content is easy. We've focused about it for years. Talk about any chronic disease. The access to it is something we can innovate in, and this is innovation in the process of delivering it. There are opportunities when they are having major surgery, for example. There are opportunities at schools. There are opportunities with when patients come for checks, health checks in their employment. So I think a little bit more focus on the access and innovation on the way how patient would access the information. How would you access the patient at the right time to deliver health literacy? The last bit, and just quick 2 points onto the future or innovations on that. And one of them would be the predictors of outcomes that we can work through with AI models, and also more of personalized care or tailored care or whatever you call it. So again, understanding your family history, your background, your comorbidities can now be used very well with AI models to predict trajectories related to how you would do after major surgeries, how you would do with good or less good management of your diabetes and so forth. So using AI for predictions onto the trajectory for the healthcare, I think that's a very important one into the technology. The second one is mainly related to literacy, again, health literacy, on how can we push all of the advances in technology and advances in wearables, media, social media, to improve the level of pushing the right health message through early on, consistently, and empower primary care and patients to deal with that. That's my...
Thank you very much indeed. That was very, very thoughtful. Fatima, your thoughts, please.
Okay, so my thoughts on the strategies. First of all, I don't see that it's only one strategy that we can work on for the chronic disease. How I say it, it could be a comprehensive ecosystem approach that we can tailor this chronic disease management for our patient. It's all of them, they are sharing, either if it's diabetic, hypertensive, cardiovascular disease, all of them sharing the same risk factors, lifestyle, the system, the ecosystem, and everything's shared together. So we have to work on different strategies on different level. One of them, when we're saying we're working on the integration of the care model. So whenever we're talking about the integration between the primary, secondary, and the tertiary care centers, not just vertical, and even horizontal. And this is what the Ministry of Health have been worked on with the model of care to integrate the cares in all the primary health care. So caring about early prevention and early detection, and then going after that to treatment and long-term care. So this is one of the things that we really need to have it. And then the other strategy is working on building the capacity of the primary health care, as this is the gatekeeper for us. So training the physician, training the healthcare provider there, this is one of the big assets that we need to work on it as big strategies that can help with our chronic disease management. The other thing is having our patient to be centered, but we have to tailor it to our culture. I guess we have seen a lot of numbers today. If we're saying that 25% of our population with different age group are being diabetic, so we need to really consider our culture when we're talking about this. I cannot just go to this patient and say, be in diet and avoid, let's say, one of our famous dishes like al-kabsa. Okay, so when I'm saying this, this is 25% of our population telling them, avoid something that will be in front of you on a daily basis. And instead of this, let's tailor it to our culture. Let's have it in a different way, more healthier way to be done. So this way, it can be adapted in a different way to our patient and even their family, as we are a family-oriented place also. Other strategies that can work also is the early detection campaigns. Early detection campaigns, like one of our famous early detection campaigns working on Know Your Numbers. Know Your Numbers was a very huge national campaign, national-wide, encouraging individual to go to Sahati application and to put their number, either if it's blood glucose or your blood pressure, know your waist circumference, and what's the relation with the BMI, and what's your risk factors, and giving you a clue by entering those small numbers. Where are you? What's your status health? So this is even after we can work with different community-based approach also for screening, either in work, malls, schools, and different places. So all of this, it can be worked together as different strategy to for our chronic disease. And we're talking about how can we empower our patient, empowering our patient when giving them the knowledge and giving them all the empowerment they needed and the information, and let them have the decision. They need to have medicine A or need to have the medicine B, let them have it. Whenever they are engaged in the treatment and the lifestyle, they choose it, they will be more adherent to this treatment, because this is a lifelong journey. So we need them to be with us on this journey. Other than this, I think we all heard about the previous presentation. We're talking about we are a very young generation. 70% of our population younger than 35 years. And most of us, more than 90%, using smartphones, connect to the internet. So we should not be afraid by using technology and AI. We're talking to our patient. So this will give them a very powerful tools to use it to manage their healthcare, their system, what's their decision they wanted to do it. Especially when we're talking about prevention and early detection, it's a very helpful tool to use it. This is how I see it regarding strategies and how we can empower our patients.
Thank you very much indeed, Doctor. Professor.
Thank you very much. And in fact, I felt very happy today that cancer is accepted as chronic disease because it wasn't at all over the last 2 or 3 decades. I remember when I came back to the country in 2000, and I tried to implement what I have taught in Europe. I cannot, because most of our patients will come diagnosed, and within 2 to 3 months will be dead, unfortunately, because all of them, they come at stage 4. And I think we have to congratulate ourselves in Saudi Arabia that we flipped the coin. Nowadays, according to our record and registry and statistics, 60% of our patients with cancer is alive nowadays. And we have now in Saudi Arabia more than 200,000 patients. They are cancer survivors. And those patients need to be taken care of outside cancer centers. Cancer center cannot accommodate all these numbers of survivors. They have to move outside the tertiary care and cancer center care to the primary care or other areas. Those patients have their own needs. Most of them, they come to Riyadh, travel just for prescriptions, just refill of their medication. Some of them, they came just to have a CT scan or MRI or PET scan. And cancer center now became full of patients. And that's the way that we doing care of cancer nowadays is not the right way. I think those patients, after they being labeled as survivor, after 5 years of treatment, they have to move to another arena, which is the primary care. Nowadays, any health giver, when he sees the diagnosis of cancer, the simplest thing that you do just to refer patient to the tertiary care centers. And I think this is a very wrong practice. How we come to this area now with a lot of 100,000 of people alive with cancer, because we implement a good plans, especially in prevention. Nowadays, we're talking about screening, either for breast or colon or cervix. Talking about prevention of cervical cancer by vaccination. We vaccinate all the liver cancer. I mean, hepatitis B. It is one of the mandatory vaccines in Saudi Arabia. And we did very well in the prevention side. I think we are going ahead to have better prevention for cancer. There's a program for smoking cessation, and there is society working on this side. But at the end, we have to think in long term. The lecture of Professor Khan just a few seconds ago is alarming. I think by 2050, we're going to have 500,000 cancer survivors in Saudi Arabia. And this is going to be soon. I'm talking about survivors. And we're going to have also the number of incidents will be doubled, because we're going to be aging population probably in 20, 25 years ago and 25 years ahead. And we're going to have more cancer patients diagnosed, either by the early detection programs or because of aging itself. I think we have to be prepared for this kind of dynamics in cancer. In addition to the problem, financial problem, for the targeted therapy, which is coming now, and it's so expensive, either immune therapy or gene therapy, and another modality, which is going to be a demand for the patient. And those medicine, basically for patients in stage 4, most of them in terminal care. Yes, we spend a lot of millions of riyals for the patient just to improve their survival by a few months, sometimes a few weeks. I think we have to work more and prevention and early detection, and also to get the patient who been cured from cancer outside the cancer care to the primary care. And we have to have this part of training of the primary care physician, and we have to give them more access to imaging for lab tests. So we're going to serve more patients with acute stage in cancer care.
Would you like to say a bit more? You were admirably short in your introduction. After listening to the three panelists, would you like to say any more on reflection?
Yes, absolutely. I was telling you this morning when we had our brief, I was like, I thought that this session is about, talking about clinical management of the chronic diseases, but it was music to my ears to see my colleagues who are working in clinics talk about prevention. And not only the prevention before coming to the clinic or what's happening in the community, it's even for the patient when they leave the hospital, when they leave the clinic, how can we prevent them from not coming back again? And one of the stories that, not stories, well actually, it's one of the facts that we're dealing with in Saudi Arabia is obesity. When we talk about, the bariatric surgeries, it is very sad to read the research and know that the relapse percentage of Saudis undergoing the bariatric surgeries, the relapse percent is 90% of the patients, go back to their original weight. And why is this happening? Because we left them without, prevention. We left them, to deal with, the aftermath of the surgery in order to, to avoid coming back to the hospital. So prevention is not about, the community and the well-being and the wellness. Prevention also plays a huge role when we are, when we're, dealing with the patients in secondary hospitals and secondary, care provided to them, or even the tertiary after the surgery. So this is number one. And, this is, very important for us and the Public Health Authority is to, promote talking about, tertiary prevention inside the hospital. This is not something, and I would like, I'd like you, doctor, to talk more about this, and how important about this. I know that in Saudi Arabia now we're currently happy that our population is young, but they will never be young forever. We will be dealing with an aged population in, in 10 and 20 years. And in our plans, we're not planning for today. We're planning, to have a productive society in 20 to 30 years. We're not planning only for now, but we are also planning for, for the generations to come. And as our evolution, presentation said, the aging population, the frailty, and the wahan that you talked about, Doctor, I think in Saudi Arabia, we need to prepare for that. And I think the model of care is going to be the tool that we use in order to penetrate all what we have, talked about in this session. So this is, yeah.
Well, thank you for that, Doctor. You've asked the vascular surgeon a question. And just before we let you answer the question, I have the privilege of doing these events quite often around the world. And I was just saying in the green room before, this is the first time in my professional career that I've seen or heard a vascular surgeon talk about chronic disease management. And I think we can all agree he's doing a very fine job, isn't he? Please, over to you, vascular surgeon.
Oh, maybe I'm in the wrong panel.
No, you're in the right panel.
So actually, interestingly enough, I've had a lot of thought about that, and I will reflect a little bit on our experience at Guy's and St. Thomas's and my relation as a surgeon to chronic disease, which has evolved along the years. I mean, we are surgeons. Are there many surgeons in the room? Any surgeons? All right, okay. Well, that's very good. I think as surgeons, our relation, most types of surgeries, our relation with the patient is around the time of the operation. And of course, we see it as something very big, because one, because we're surgeons, two, because sometimes it's big. But the reality is with chronic disease, the patient is already having a lifelong healthcare issue that is with them. And you are an episode, as the surgical hit, is an episode in that timeline that comes in, interact with the chronic disease with whatever way, which I'm going to touch on, and then leave the patient in a shape, sometimes the baseline, sometimes less than the baseline. So it becomes a hit during the healthcare journey or lack of health journey if they're suffering from chronic disease. And I would like to see this as, or to talk about it in 3 different areas where I think a lot of attention and potentially input can change management of chronic disease. Pre-operative side of things, we have a specialty that is a subspecialty of geriatric called POPs, peri-operative physicians. I think it's spreading all over the world, and we have been one of the founders of that, and a couple of my colleagues have written fantastic healthcare economics impact on that, and also outcomes of surgery related to peri-operative physicians. And we have them across many surgical specialties. So on the pre-operative side, there's a lot of interventions that you can do classified as optimization to surgery, and many of them are just catching up with the lack of good chronic disease management. So a lot of it is, if the blood pressure was not well controlled, well, let's get on top of that. If the diabetes was badly controlled, well, give us some time. If the respiratory function was not good, oh, we need to deal with this. So some of it is optimization, and in many occasions, it's actually optimization by catching up of chronic disease that has not been dealt with well, or has been a little bit deteriorated by the problem that brought them to surgery. And the second one is the preparation to surgery, and they do a fantastic role in this because it's not only the physical preparation from readiness to anesthetic and long operation, if it is long or whatever type of surgery, it's the psychological and social preparation. So they start almost the discharge planning in the preoperative period by looking into multiple factors related to their discharge issues, with, of course, all of the odds of they might be on their baseline or not. Moving on to the operative side, well, they are higher risk. They need usually specialized centers. They need special anesthetists, and their complication rates are a little bit higher, so they need that to be part of the counseling. But also, one step backwards, the decision-making of operating or not can be crucial when you put the frailty that I mentioned earlier, the multiple comorbidities and chronic disease into the equation. Because what you want is health span, not only longevity. What you want is not technical success of surgery. You want a good outcome and a good functional outcome of that surgery reflecting on health. Last but not least is the one that you've touched on earlier, which is what do we do after the operation? Well, the odds are they are a bit worse, so we need to manage them in the primary care and in their social care with the support. They might get back to their baseline. Rehab facilities, and we talked about that earlier, a place somewhere between the tertiary center and their homes that can manage this journey of coming back to their baseline is essential within the model of care. And finally, I have had patients where I've done, let's say, aneurysm repair, an asymptomatic disease. You do it because you don't want the aneurysm to rupture. But they have benefited from the hospital admission far more from the medical input, optimization of the blood pressure, diabetes. And I feel like, yeah, well, I've done the aneurysm. It could have ruptured, it might have not. But now immediately, their chronic disease management has got better. It is an opportunity for health literacy. And I bring that back over and over. When the patient is having surgery, this is a very good channel and opportunity for loading them with some health literacy, also engaging family and engaging patients into their own care.
Well, as we heard earlier, every contact counts. Can I ask our Saudi colleagues, are the clusters making sufficient progress as quickly as possible? You can all answer it, or none of you can answer it, but I'll ask you an even more difficult question. So why don't you have a go at that? Are the clusters seizing CDM as a priority?
Well, from the Public Health Authority, because, we're trying to manage now, the screening programs, the early screening. And as I have, mentioned to you, and I'm mentioning it to our colleagues, the problem that we're facing in the system now is that when it comes to diabetes and when it comes to hypertension, we have, the unaware patients who are, in the outside world, and they don't know it. So what the clusters are doing with us now, with the help of Holdco, is to focus on these, targeted, population. So from my opinion is I see, clusters are, paying attention to that, and they're giving it, in their model of care activities. It is being prioritized, and we're, very optimistic about the progress we're witnessing.
Can I just push you before we come to Fatima? Most countries have national ministries or departments in the ministry
Yes.
where they are evangelical over chronic disease or child health or cancer. And then obviously being a chief exec or a manager in a cluster, you are made to feel inadequate and humble because you're not making sufficient progress on each of these disease areas. How do you make sure that chronic disease management is a priority in the clusters? Is it persuasion? Is it direction? Is it humiliation? Encouragement? What techniques are used in Saudi Arabia?
I would say alignment, but the true alignment.
Very good.
Yeah, because, a few years back, I was like, when I finished my policy, education, and I was like, what's happening in Saudi Arabia when it comes to alignment is that, people do not align actually together. This is what's happening. They claim that there is alignment, but it's not. But why I'm witnessing between the Public Health Care Authority and the clusters when it comes to activating the model of care, especially in the screening, I think there is a true alignment, because what's happened is that our colleagues in the clusters, they're putting their challenges and they're putting their, their strong points into, and really, using their enablements, to facilitate the screening process, and this is happening. And back in the Public Health Authority, we absolutely understand these, we absolutely use these, respond to these challenges as much as possible by not putting, or throwing our partners under the bus, and we would say, we're not hitting the targets because they can't. It's because they can't because they have challenges, and we need to respond to these challenges and identifying who is responsible for these challenges. Would these challenges be related to resources? Are they related to leadership? And then we go back, it's a learning cycle, I would say. It is highly communicative, and I'm saying this because this is absolutely what's happening now with our colleagues in the clusters.
That's a really great answer. It's very diplomatic, and you should be a politician.
Honestly,
yeah. That's a really good answer. Fatima.
No, but because, there are challenges, yes, of course, but these are challenges. We're not trying to create conflict. Conflict is the last thing that should happen. And we need to, work hand in hand in order to overcome these challenges. They exist, and we do have, I won't say fights, but we do have disagreements of how to deal with them. But we're trying to find a solution together, whether you call this a diplomatic, but this is honestly what's happening.
Yeah, no, I can feel it. It feels very heartfelt. You should still be a politician, by the way. Fatima.
If you allow me, I think that's our secret word, the alignment, that we use it always in the health. So definitely I echo what Dr. Taghreed just mentioned, but one of the things that we need to really work on it is to have the analysis on the data-driven as a public health decision. So whatever data we are having from the model of care, from Public Health Authority, from the Ministry of Health, we need coming from Sahati, coming from HIS system, we need to analyze those data to work on it to make our policy decision. So this is one of the things that if we work on it in let's say in a public health way, on a preventive, on screening method, that will really give us a very great outcome. This is as a public health background, so this is how we think morally.
Thank you very much. And Professor?
I think we're doing very well. According to our records, the number of patients coming diagnosed in early stage is very high now. Most of them, 50%, are coming in early stage. I think we're doing very well. The model of care is built in a nice way. It's about prevention, about care. I think we need to do more in the capacity because we're going to have more patients, unfortunately, and more chronic patients. I think we are utilizing the technology very well. A lot of cases now managed virtually by telemedicine, teleradiology, telepathology. I think we are doing very well in that part. The ecosystem is going nicely and smoothly. We should not jump to see the result now. Take times, take decades. I think we need also to help the family to take care of their beloved patients. I think they need to be supported by the policy, by supporting their financially or administratively, either by certificate of visit. You can see here between the audience, two of our colleagues, they were taking care of their father when they have cancers. And most of them, they can't work during that time. So I think also the health system should help and encourage the family to take care of their beloved one. I think we need to build capacity in rehabilitation because that will reduce the chronicity. Also, we have to reduce the number with chronic diseases with the new modality of treatment. Nowadays, for example, we have here in Saudi a problem with thalassemia and sickle cell anemia and so on. And they lived chronic disease for 40 years. Now there is a new modality of treatment like transplant, which cure them and move them from chronic disease to just ordinary person. I think we are doing well. We have to continue doing that and don't run or jump to the result because the result will take a long time to be feasible.
Well, I'm sure I hope you agree, this has been a fascinating session, especially when juxtaposed with the prior speaker as well. I'd like to thank you, Doctor and Professor, and it's great that we've got a vascular surgeon talking about chronic disease management. Would you show your appreciation, please, for the panel?
Now we will take a short break and we'll continue our discussion at 2:30. We are also pleased to invite you to attend the closing ceremony in the presence of His Excellency, the Minister of Health, to honor the winners of the Model of Care for 25 at 7 p.m. كما يسرنا دعوتكم للحفل الختامي برعاية معالي وزير الصحة لتكريم الفائزين بجائزة نموذج الرعاية الصحية لعام 2025 في الساعة 7 مساءً.
Ladies and gentlemen, welcome back. Our next keynote is titled Digital Health, Enabling Model of Care Implementation, where we will hear of practical applications in scaling personalized care by leveraging data and AI. Please welcome back to the stage Professor Richard Hobbs.
Well, good afternoon, and thank you for persisting with the session. We're coming to the end of this two-day Congress, which I think hopefully has had all sorts of interesting snippets of information and ideas for how we can better reconfigure healthcare systems. So I'm going to talk about digital health and AI, and I'm going to look at some validated examples of how it might and has changed clinical practice. But I thought it was worth just posing ourselves a few questions at the start, which I'm going to pose you as the audience in terms, I won't go through all of them, but let's just pick, for example, the first question. Do you think that AI and digital health will substitute and replace some healthcare professionals? Hands up who thinks there will be some role substitution from digital health. Okay, a few hands have gone up. What about the number 3? Who thinks actually it'll be a bit of a damp squib? It'll have no effect on healthcare? Well, nobody thought that. But what about number 5? Who thinks it will improve the quality of care? Well, that one has got the most votes. So I think the reality is that at the moment it's a bit difficult to predict where digital health is going to take us. I think that, frankly, number 5 needs to be the priority, which is it is aimed at producing more effective and hopefully more efficient healthcare. And I think as physicians, we need to believe that we'll be involved in that process, and therefore number 4 is actually going to be quite important, that we see it as a way of enhancing our roles. So in terms of AI, I think AI is a term that encompasses quite a number of different, on the left there, different analytic, statistical and computing methods that end up being things like machine learning and natural language processing. All of them are encompassed within the overall term AI. But I'm going to talk about some practical examples and have clustered them around big database utilization, risk prediction models, a few words on clinical pathways, and imaging analysis. And I'm going to start off just thinking about the use of the routine EHR, electronic health records, the big data that is a consequence of that. And I'm going to mainly focus on its potential use in acute disease surveillance and tracking for obvious reasons. Some of the advances in use occurred during COVID, for example. But it can be very useful for that second point of getting real-time data on the burden of disease in the population or the burden of risk factors, this idea that we have a more controllable health system. But it can actually be used to actually reconfigure what we do in clinical practice. And I'll give you an example of a system-level feedback of performance, this idea that audit and feedback changes practice. And I think we're only scratching the surface at the moment, because all of the information that currently uses big clinical databases is using the coded data. And about 90% of EHRs currently comprise uncoded data. It's the free text rather than the coded information. And there are a number of groups, ourselves included, who are experimenting with creating infrastructure that has the totality of the clinical record. And I think that's going to really start levering new results in terms of AI. But let's just look at acute disease surveillance here, and this is something that we do in my department in Oxford. We run a parallel system to the public health laboratories for acute disease surveillance, and we do it at a fraction of the cost of the public health laboratories because we've tacked it on to routine clinical practice with a sentinel practice network of 200 practices who, in addition to doing routine care, actually do some virology sampling of patients presenting with respiratory illness. And over the years, this network produces a weekly service for the UK Health Security Agency, previously Public Health England. And these are the data that was taken during the pandemic. And the graph that you see inflected up, the first column is actually our network based out of Oxford. And next to it, tracking the incidence of COVID this was presenting in the population, is the public health laboratories. And in fact, our system, which is a low-cost system because it adds on to clinical service, actually is detecting acute illness about a week before the big public health laboratories do. And in fact, the first case of swine flu, of COVID in the United Kingdom was in this low-cost surveillance system. So that linking of acute monitoring of infectious through virology and link it into the clinical systems can produce actually low-cost surveillance. What we also did during COVID, which is quite interesting, is look at the potential for acute tracking. And this was based on the NH app that you heard about yesterday from Tim. And basically, I think with pandemics, you've got a dynamic, because if you have a pandemic where on the x-axis here is the proportion of infections that occur prior to symptoms. So if you have a pandemic that has a long asymptomatic period and it doesn't have a very high mortality rate, we think that COVID killed a lot of people on the planet, it did, but its actual case fatality rate was relatively low. That's a big problem because those are the dynamics that are going to produce a lot of global infections, unlike SARS, where the case fatality rate was very high and patients became symptomatic almost straight away, so it reduces the likely spread. So asymptomatic disease, how do you detect that? About half of the population being asymptomatic several days whilst they were infectious. So if you use geo-tracking on people's phone systems, you can have a subject here, subject A, who is well and goes to work on public transport, mixes people at work and then goes home, but wakes up the next day on the bottom with a fever. So using their app, they can immediately report a home test result because they've got a kit at home. And if that's positive, that can then go as a signal to the people who were in close proximity to them, assuming that they'd switched on their geo-track devices. And you can get an amber alert that says you were actually quite close to somebody who has symptoms. Please don't go and visit vulnerable people and be prepared to quarantine yourself. And then if it was positive, they would then get a code to get a test themselves and, in fact, isolate themselves until they were clear. Now, what this showed was that that was possible. You could do this, and something like this that would require huge participation by the audience. They'd have to give up some autonomy during the period of a pandemic, but you could avoid a national lockdown. You could get a selective, patient-approached lockdown. And if you did this quickly, if you had test results available fairly instantly, and obviously one of the remarkable things about COVID was the development, not just of vaccines, but of rapid point-of-care tests that were pretty reliable. So if you do that, you've got potential to be able to do real-time, real infection tracking like this, and it would require about 2/3 of the population to accept it. And you'd have huge impact on the incidence of the infection going through the population. And if you think that what we were doing with a national lockdown was trying to blunt the spread of COVID within the population, to give time for vaccines to be developed, but more importantly, to actually allow the health system to manage the patient burden over a period of time rather than it all hitting in one go, then huge issues about personal freedoms here, but it is an alternative to national lockdowns, and I think those sorts of things are going to continue to get experimented with. Now, we also talked this morning about performance, pay for performance, and feedback of information, and certainly something that we do as part of the surveillance system is have audit feedback to practices. So on the bottom here, individual practices in orange will see their performance related to their national comparators, and a lot of information on the top there that they can use to actually improve their performance, because you're automatically feeding back the parts of their practice population that they're missing. So you're doing some of the work for the practice in terms of public health identification. And you can also do this at a bigger level. This is based on regional health authority equivalents, so it's a population of perhaps 2 to 3 million. And what you can do is compare to whatever you're measuring. In this case, it was the switch from a high-cost proprietary drug to a low-cost generic that had become available. And the blue line is the national performance. That's what, on average, happened across the UK. And the red line are different authorities. So you can see in this one, in Gateshead, they were very slow to adopt this change and then had a very rapid change. And on the top there, you can see the health authority actually introduced this change earlier. Now, this is based on Open Safely, which is an open source database on NHS performance. And you can use this system that provides national data at very low cost to develop to routinely monitor interventions that you're going to do in a health authority setting. So you could imagine a health authority wants to change something, wants to, say, increase the proportion of patients who are having their screening, say, for cervical cancer. You can do an intervention and you can test on a routine access system what the impact of that system-level intervention is across your population. Previously, that would have required a bespoke evaluation system to be set up and it be replicated every time you wanted to do it. So having routine infrastructure that enables more evaluation of actions, I think, is highly useful. So let's just turn now to a different use of AI, that of risk prediction. And again, an example from COVID, again using the Open Safely database. This was a national database that was established very quickly in the first few weeks of the pandemic. And they were amongst the first, again, it was based in my department, and the investigators in this, led by Ben Goldacre, were amongst the first in the world to identify the risk factors that actually produced more serious COVID, requirement for admission or death. And they identified what you'd expect. Anything that produces immunocompromise in an infection is likely to produce more serious disease. But they detected that immunocompromise in the population isn't always just for obvious reasons like hematological malignancy. Inevitably, it's going to affect your immune response, or organ transplantation, where you're taking immunosuppressants inevitably you're likely to get a worse response. But I don't think we had predicted that obesity actually has quite a profound effect on producing immunocompromise, and indeed EGFR, reduced kidney function as measured by EGFR stage 4 onwards, actually had a really big predictive for worst onset COVID. So what you can start to do then is develop a tool, and indeed we developed the Q-COVID score, which the UK government used to determine who got the vaccine in what order. Everybody's going to get one in the end, but you obviously want to give it to the most high risk first, and also a more precise measure of who should shield themselves from meeting family or friends because of their immune state. And these risk scores have been around for a while. The most used ones internationally are cardiovascular risk scores. This is Q risk score, but there's also obviously Framingham equation or SCORE equation in Europe. These have all been around for quite a long time and are used by many health systems to decide in your population who is at most risk of vascular events and therefore is worthy of getting interventions such as statin therapy. But the trouble with a lot of these algorithms, although they're reasonably accurate, area under the curve are about 80% or so, they are only as good as the amount of information in the clinical record. And in fact, for many patients, they only have a partial record of all the risk factors that you use in these algorithms. And then you end up with a less precise measure because there's a degree of imputing the results where the result is missing. And again, AI, I think there's been some really exciting research recently looking at this question: can you predict who is at high risk with traditional risk factors? And this is some work based in London looking at retinal images, just doing a retinal image and then mapping it against the observed risks in the population. This was using Biobank. And really surprisingly, I think, because I don't think any of us would have predicted that a retinal image would predict your vascular risk factors, it was really quite accurate at predicting age, gender, whether you were diabetic or not, your hypertension status or not, and even your weight. And in fact, a group in China has followed this up by looking at a predictive rule that was looking at the likelihood of detecting chronic kidney disease. And again, the red line there is the retinal image beating the traditional risk factors in green there. And they also did a subgroup where they did a retinal image just using a smartphone and a lens to take the retinal imagery. And I think what we're hoping to do is replicate this in larger populations and validate whether this is a simple way of detecting vascular risk. So imaging analysis, I think, has been the obvious area where AI has already made an intervention. I've chose one example here, which is breast cancer screening. And a group basically trained an algorithm using UK data. UK has 2 specialists read mammograms, but our follow-up is usually 3 yearly. And they then tested that on a US database. US only uses 1 reader, but they do mammography more regularly. So again, the volume of information, data available, is similar between the UK and US. And in fact, this UK-derived system producing areas under the curve of nearly 90%, which means it is pretty predictive of significant lesion of cancer. Isn't going to be 100%, but it is really pretty good. And what I think will happen with things like image analyses is that in settings, well-developed health systems where there are specialist readers, the specialist readers will give an initial interpretation and then will double-check by looking at the AI imagery. In lower-cost health systems, I think we will switch just to AI algorithms, and the advantage of those is that they will be the same performance 24/7 and don't take 30 years of training, and it can only get better as you add more and more information to the algorithm. And indeed, if you test this system from routine practitioners, not specialist readers, then the black line is the AI and the colored line is the routine practitioner. In their testing, it outperformed the routine reader in every case. So the last area I just want to give a few examples are clinical pathways. And I think through this you can potentially develop healthcare solutions. This is a really quite simple intervention. It's work we did looking at giving validated blood pressure machines to patients and giving them a computer algorithm to determine what they did with the readings, whether they up-titrated or even sometimes down-titrated treatment. And we showed in this population, the intervention was 6 months, that it produced a 4 millimeter mercury of reduction in blood pressure, which actually increased over time to 5 millimeters, which may not sound very much, but those are the expected epidemiological benefits of a 5 millimeter reduction of blood pressure. And in fact, it's equivalent to at least half an additional active medication. And the important thing is that it's reducing healthcare utilization. It was a dominant strategy. It was cheaper than the system of patients just routinely going to the practitioners, and might actually be effective for about 20% of the population in a high health cost system. In lower systems, particularly rural communities, it could actually substitute safely for clinical practitioners. And there's also quite good work looking at really simple technologies like phone texts to increase the rates of uptake of medications. This data was derived in Soweto in South Africa. And I think there's a whole new generation of more digitally enabled clinical trials. That's something I think the Kingdom can take some leadership in. If you've got the right infrastructure to digitally enable clinical trials, then I think you can do many things with it. Real-world evidence can sometimes give you answers early. This is early data from GLP-1 receptors used in routine practice in the UK versus SGLT2s, showing actually an early signal of reduced rates of heart failure hospitalization. And subsequently, that was demonstrated in a landmark trial. On the left here, less than $1 million. On the right, $120 million trial. Very similar results. And I think we will see more real-world evidence trials complementing or being used with clinical trial information on smaller studies. And sometimes you'll only get the answer from a real-world trial. Metformin was contraindicated in heart failure because of lactic acidosis, but sometimes patients get on it, and you can then monitor that. So lots of small studies reporting on the use of metformin in patients with heart failure. Important because metformin is the cornerstone of diabetic treatment, and many patients with heart failure also have diabetes. The pooled results of all the real-world trials actually showing a benefit, and FDA removed the label subsequently. We've also got data on pharmacosafety from real-world evidence. These were data very early on in the pandemic around the relative safety of vaccines. In the purple and the orange, that's the side effect associated with the vaccines, a bit of a signal even early on for central venous sinus thrombosis. But the important thing is that the purple are patients who didn't get vaccinated, and basically you can see that their rates of these adverse effects are much higher. So although the vaccines might produce a small increase of rare adverse events, not being vaccinated and getting infection, you're up to 10 times more likely to get that same adverse event. And I think you can pull some of these techniques together in digitally enabled trials, which is what we did during the pandemic. and very rapidly report on drugs that we thought might work. This is all pre-vaccination, and we're able to show none of them actually were effective, other than inhaled budesonide, which did produce a positive result. But these are important negative data because it stopped us doing things like giving antibiotics to patients with COVID. And indeed, we pulled this together for the panoramic trial, which was a big national trial we ran to look at the safety of molnupiravir and the efficacy of that. And we were able to recruit 25,000 acutely ill patients in 4 months in the United Kingdom, with virtually everything run out of Oxford. 60% of the patients were recruited and followed up in Oxford. We had patient-delivered online follow-up in terms of outcomes. So I think in summary, what digital health is going to do is going to transform health systems. I think we're investing in it in Oxford based on the department there. We renovated part of the old Radcliffe Infirmary to base the Department of Primary Care a few years ago. It is the building that had the first administration of penicillin on the planet. That's the green building on the right there. And what we're hoping to do is convert those old buildings at the top into a new Oxford Institute of Digital Health. And importantly, that'll include teaching space, because we're now running Masters in Digital Health, Masters in Global Healthcare Leadership, and an MPH, all based in this historic location. Thank you very much.
قبل تقديم المتحدثين للجلسة الحوارية الأخيرة لهذا المنتدى، نود تذكير الحضور الكريم بالحفل الختامي مساء الساعة 7 برعاية معالي وزير الصحة الأستاذ فهد الجلاجل، والذي سيتم فيه تكريم أخواننا وأخواتنا وزملائنا وزميلاتنا لأعمالهم في نموذج الرعاية الصحية لهذا العام. Before presenting the panelists and the final panel discussion, this is a gentle reminder for the closing ceremony at 7 p.m. under the patronage of the Excellency Minister of Health, Mr. Fahd al-Jalajal, where there will be recognition for our brothers and sisters and colleagues in healthcare for the efforts that they have done in the model of care for 2025. Now for our final panel discussion, with a wealth of knowledge and expertise among the panelists, we'll focus on envisioning the future of integrated care globally and locally through discussing emerging trends and visionary perspectives. Moderating this session, we welcome back to the stage Dr. Luis Lobon.
Good afternoon, everyone. Thank you for being here for the last session of the Model of Care Forum 2025. We have an open chair that will momentarily be occupied. So in the meantime, we will get started. Thank you, Dr. Wallman. Thank you, Professor Lidge. Pleasure to have you both here. And it's time to start thinking about Model of Care 2.0. We have heard a lot of the advances that the Kingdom has achieved and success stories in launching the Model of Care initiative under the Healthcare Transformation for Vision 2030. Continuing with the topic of the forum, which is the patient-centric integrated healthcare system where technology and innovation are key components to move the provision of care, research, and other healthcare areas forward, let's start dreaming about what is coming next. So in that context, I think there are some perhaps unfinished business from model of care 1.0 that we probably will need to touch on. So let's start talking about quality and safety of care, Professor Lidge. And as the system, this vast system countrywide gets integrated, different clusters at different speeds, different needs, is it time to take a moment and reflect on how quality and safety is being structured, standardized, followed through, strategized upon? The concept of the quality and safety warehouse for our model of care in the kingdom. Perhaps you can share with us some of your lessons learned during your time in the Scottish healthcare system, addressing quality and safety. Thank you.
So I'd be delighted to. Thank you again for having me. Thank you for staying. This is the hardcore.
That's the hardcore.
This is the hardcore who have stayed to the very end. I hope we don't disappoint you in your staying. So I am a little biased because my job for the last 14 years in the Scottish Government was quality and safety. I was the point guy for quality and safety for the politicians. So if there were a safety problem or a quality problem, the politicians would unfortunately come to my door and make me the problem rather than the safety or quality of the problem. When I'm asked what the core challenge of healthcare is, I can of course make an argument for public health. I can make an argument for chronic disease. I can make an argument for any element of what we're trying to do. But when you take it down to its absolute basics, it is about the quality and the safety of the delivery we give to patients and families and carers. Whether that's advanced cancer care, hospital at home, social care, public health care, it's fundamentally the core for Scotland became quality. And in 2010, I said this yesterday, we published the quality strategy, and we deliberately called it the quality strategy. And the minister at the time, Nicola Sturgeon, who subsequently went on to lead the country as the first minister, stood up in the national parliament and said the only thing that mattered was the quality of the delivery. She said, this is my focus, this is my priority, and I expect the 165,000 employees and, unfortunately, Professor Leach to lead that mission. And it feels not dissimilar to what this country is going through. You're doing it more quickly, and you're doing it probably with more ambition than Scotland had. But we learned a number of things along the way, and there are 4 hours of lecture on what we learned. But let me try and summarize it quickly if I can. The first thing we learned is you need leaders. So you need, in my world, that was the political leaders. That was the elected political leaders to say, this is the mission. You have that. I had dinner last night with your assistant minister. Your assistant minister said very clearly to me at the dinner, as well as on these stages, that quality and safety was the driver. That's the reason for doing this, for the families, for the citizens of the nation. You need engagement in the people, in the workforce. You need people to agree that this mission is the way to go, not superficially, not just because the leaders say it, but because they care deeply about the patients and families. And I feel that in the conversations I've had, in the people I've met, in the places I have visited. The third thing, and this is what we didn't have, the third thing is you need a method by which to achieve that end. And there isn't, I wish there were a secret sauce I could just hand to Saudi Arabia and then we would all go home and everything would be fine. I had probably the highest quality system in Europe is in a little obscure county of Sweden called Jönköping County. It's 250,000 people. It's probably the best healthcare in the world. Probably. It's tiny, absolutely tiny. And I know the chief executive very well, and I had dinner with him, and I said, how did you do it? Expecting him to say, we got this magic secret. And his answer was extremely profound. He said, we just did everything. I said, what do you mean? He said, well, they came and told us we should do public health. We did public health. They came and said we should make our hospitals safer. We made our hospitals safer. They came and said we should do chronic disease management and find the really sick families and work on the really sick families. That's what we did. They said we should adjust the payment method to incentivize quality. That's what we did. I said, you mean it wasn't simple? He said, no, it was a generation. It took us years. But when we did everything, we ended up in the right place. He would be the first also, if he were here, he would be the first to say, we're not finished. We're now working in elder care, we're now working in social care to try and improve them. But the Swedish example of, unfortunately, there is no shortcut. You have to do everything. But you have to start somewhere, and Scotland chose to start in patient safety. That's where our method began. It's where we learned how to make improvements and change. So we fixed patient safety in acute hospitals. We eradicated infections. We reduced mortality by 1/3. We reduced surgical mortality by 1/4, doing safety interventions. And then, having learned that over here, with expertise, with people coming from the States and from Europe to help us, we then moved into chronic disease, into mental health, into maternity services, to try and improve the quality of everything else. But we started somewhere. And that's my final piece of advice in this long answer to your question, is you have to start. Because the just do everything feels overwhelming. It feels like too much. So we're just going to bury our heads and hope it all goes away. But actually, you have to start. And I think that's what Scotland did. And we started with safety. You can start wherever you like. You can start with maternity. You can start with chronic disease. But you have to start. And that's what the principal lesson for us was.
Thank you so much. And, a great model to follow, that Swedish, do it all. But I think the point about, scaling, the effort, focusing on maybe most immediate needs, and then scaling that effort to the overall, system of quality and safety is what you're hearing from you.
And there are known scientific methods of how to do that. There are methods you can learn that allow you to start in one intensive care unit, one family physician practice, one home, and then work till you get to the whole nation or the whole cluster or the whole hospital, whatever it is you're trying to do. That is knowable. You can learn that science.
Yeah. Great. Thank you so much, Professor Lichen. Dr. Wallman, just maybe moving into that phasing of, the effort, the transformation, coming from Kaiser Permanente, a system with many, many entities across, the United States. Any tips for the clusters and the health holding company and others in other healthcare systems in the kingdom on how to advance them all and move them in the right direction, acknowledging that there are differences, acknowledging that there's variability? How do you actually engage your systems to move forward as one?
Sure, I think that's a great question. Also, I love the phrasing that he said. It reminds me of the Mandarin Chinese saying, a journey of 1,000 kilometers begins with a single step. Start somewhere, but just start. It's very easy to be afraid by the long journey you have, but take that first step, and whatever it is, let that be the first and get you moving. I think the question about how to spread best techniques, that's a challenging one. So in Kaiser Permanente, we're in about 9 U.S. states, 12 million patients across the country, and I wish to say that where we had best practices in one place, let's say in Washington, D.C., that everywhere else immediately adopted it. But I'd be lying to you if I said that that always happened. And I think that's a challenge that I see with the 20 plus clusters, is that you have fantastic leaders, fantastic physicians, fantastic staffs, and you will get best practices, whether you learn some of it here or develop it on your own. But I think the challenge is, how do you spread a true best practice around the entire system, around the entire country? And I wish there was, a magic saying or a bottle of water that would enable to do that easily. And that sort of reminds me of another saying I like is, doctors don't like change. Healthcare systems don't like change. It's very hard to do. Physicians get very entrenched in how they've always done it. And I think one of the ways that we've helped move things forward is sort of what I like to say is, whenever you get the pushback, well, we can't do it your way because this is how we've always done it. Whenever you hear the phrase, this is how we've always done it, that means stop doing that. And do it a way that objectively, don't change for the sake of change, but when you have an objective best practice that objectively increases access, increases quality, that you put that objectively into the hands and the minds of the leaders of the different clusters or different regions, and encourage them to match the policy of the best. And you can't make every cluster or every region or every system develop a perfect system, but you can expect the ideal system to pop up, one here, one there, a couple over here. But you need to sort of ingrain the sense of when a best practice is objectively identified, that leaders need to adopt that into their own system. Again, maybe they may come up with an even better system, and then the system that came up with the first one needs to adopt them. And competition is natural, sometimes it's good, but when it results in obstinacy, no, we're not going to change because, I don't like the people in that cluster, that you need to sort of get past that. And I wish that in Kaiser Permanente we were able to get past that uniformly nationwide. We haven't been, but every journey of 1,000 miles is a single step. And my job is to, where we create best practices, to help let the others see the best practices that we create, and where others create best practices, I'll make sure we adopt it in our area as well. So sort of a long answer. It's not a perfect one, but I think it's hopefully halfway decent.
No, thank you, Dr. Willman. And so if I heard you correctly, the idea of a best practice, incubator model that others can benefit from, the lessons learned and the succeed achieved by some of the clusters, is something that could be potentially very contributory for the success of all of them moving in the right direction at one point.
Absolutely.
To model of care 2.0. So that moving into the model of care 2.0, I think needs to probably keep a very diligent leadership model with clear governance, but also empowering the active doers to make decisions. Lord Markham, you've been in that position before. The empowering of others to potentially make mistakes and feel comfortable with that situation. Could you share with us a little bit about your lessons learned in that regard? How to empower, how to accept potentially lack of immediate success as a positive, and how to really encourage others to keep transforming even if the goals are not achieved immediately.
Thank you. Yeah. And firstly, apologies, I wasn't at the beginning. I've never heard before of a Saudi event starting early, but there you go. There's always a first for everything. But no, I mean, that's absolutely right. That is the critical role of leadership here. By definition, innovation means trying new stuff.
and that means taking risks. And the one thing I can absolutely guarantee all of us here as leaders is if you're not making mistakes, then you're not trying hard enough. I always say when I go skiing, if I don't fall over, I'm not trying hard enough, because until I fall over, I don't know where the edge is. I'm a big football fan, soccer fan for Bruce here. And, you know, the modern style of football, if you see it, is all about playing out from the back. And you see them doing passes in their own penalty area. And I'm covering my eyes up, you know, and I'm saying, just boot the ball, you know, but actually, no, you know, absolutely they're encouraged to draw on the opposition to then knock it around them. And, you know, managers know when they do that sometimes they make a mess and they give away a goal. And, you know, the manager has to absolutely foster the culture that's all right. So I have what I call my first rule of holes. I mentioned it the other day. When you're in one, stop digging. And it is the real role of leadership to foster a culture where people feel okay. They feel safe enough to put their hand up and say, I've made a mistake. And that's always the first thing. And then it's incumbent of you as a leader, however angry you might be about that mistake, however embarrassing it might be, to make sure that you respond in the appropriate way. Because you can absolutely guarantee that if you respond in the wrong way and you cut them off at the knees and shout them out, however frustrated you may be, you will never, ever get anyone in your organization again admitting to a mistake. And again, I've seen tons of situations that I'm sure we all have, where people will compound a mistake by digging deeper and trying to avoid doing it. So my biggest piece of advice, and it was, you know, I had this very early on when I was a minister. I was in charge of innovation, and we were backing loads of new technologies and companies. And one came, and, you know, it wasn't doing very well, and all my civil servants were really worried about it all, and said, well, you know, the publicity will be really bad, and, you know, maybe we should back it with more money, because they're telling them that if we just give them a bit more, it will come right. And I said, look, I'm relieved. I'm really, really relieved that we've got a failure, because until you told me about a failure, I knew that when you're doing startups, you know a load of them are going to fail. And if I was getting worried that no one had told me about any of them failing, and that said to me that you were hiding something from me. And it's very natural. You know, again, some of these are going to fail, and we need to deal with it in the right way. So that's the biggest thing. But then at the same time, as Bruce was just saying, the other role of leadership is that then when you do have something that really does work, actually being strong and saying, you know, okay, we're going to adopt this. Because the very same culture and spirit that fosters innovation and people trying new stuff, of course, goes totally against then trying to implement it through, you know, implement someone else's solution because it's better, because it's top down. And that's where you really need the leadership as well, saying, look, we backed you to you know, go for the thing that you're doing, and, you know, I'm afraid there's something that's better. And now you need to take a step back, and we're going to implement this instead.
Thank you. Look, Nick, so we could talk for hours about leadership, right? But I've heard about you two talking about, although not mentioning as such, this concept of the incomplete leader. The leader only becomes complete with the team around him or her supporting and enabling the system to move forward. Empowering others to complement that incomplete leader is actually a task that we all have to undertake. And to do so, at times making the wrong decisions and accept them and learn from them. So I wanted to switch a little bit to the patient side of the conversation for the model of care 2.0. And we have heard over the past 2 days that really shifting the ownership and the accountability to patients to manage their own destiny in their healthcare journey should be part of the next wave of transformation. The question is open to the three of you. You can actually approach it from different perspectives. We have 17 minutes left. I think this is an important topic to discuss at the end of this forum.
Absolutely. So I'll go first. I think patients want to be empowered. Humans want to be empowered. And I think the goal of a top-tier healthcare system is to put the effort in place to make the patients, empower them to help their healthcare simply. I always like to say it takes a lot of effort to make the right thing to do the simple thing to do. It's easy to come up with something complicated, but to come up with something simple that works, that takes a lot of effort, but it's well worth it. So a couple of examples I can think of in my own system in Kaiser Permanente that let patients be empowered to help their healthcare. And also, it involves technology, of course. So for instance, in pharmacy, patients with chronic disease, for instance, while I was sitting here yesterday, I get a text on my phone. It says, your high blood pressure medicine will be running out. Type 123 to refill it, and we'll mail it to you and charge your credit card on file. So I'm reasonably busy. I don't want to go to the pharmacy to pick up a chronic medication. I click 123, and by the time I get back to Washington, D.C. from here in Saudi, my chronic hypertension medicine will be in my post box at home. It puts me as the patient in charge of my own health care and enables me to get the medicine I need or any of our patients need simply and easily with a minimum, without disruption to my life in general. Similarly for lab tests, for instance, colon cancer screening. We have a colon cancer screening which can be done at home. And so once a year when we approach a certain age, our patients will get mailed to them this little kit that the patient can do it at home, mail it back, and they get their colon cancer screening. And because we make it simple and easy, our colon cancer screenings are top in the nation. And hundreds of Americans would not die of colon cancer if all America had our colon cancer screening, because we make it simple and easy. So putting the care, again, it's a lot of effort to put this in place, but spending that effort to put patients empowered to their care through technology, it's going to be well worth it for an integrated population-based system.
Thank you, Dr. Wellman.
So clearly we don't have to argue for patients and families to be in the centre. 10 years ago, we would have had to have argued that from the stage, because that wasn't true. We didn't globally think patients and families should be in the centre. We thought it should be a matriarchal system where the carers would decide. So we're over that, and I think Saudi is over that. But some very practical things that Scotland has done that I think are a little bit of an example. Two very practical things we've done. The first is we've embraced a movement called What Matters to Me. It's a global movement that has transformed the question from what's the matter to you to what matters to you. So now when you go to a Scottish hospital, you will of course be diagnosed with cancer or diabetes or stroke or whatever's wrong with you. On the wall in your room will be a chart that says age, doctor in charge, date of discharge, all the things you would expect. And there will be a cross. And over that cross it will say, what matters to me? And your family, or you if you're able, will fill that in, whether you're a 10-year-old or a 94-year-old. And you will write on it, my pet, my grandfather, my favorite yogurt, my favorite football team. So to try and humanize the interaction. And it's astonishingly simple, and it completely transforms the conversation. So I've seen hard, old consultants who would barely look at patients come in and instead of talking about the liver or the dementia, talk about Rangers Football Club or pies that they prefer for their dinner or a picture of the grandchild that's been stuck on the wall. And the disease is still important. I'm not suggesting, I'm a surgeon. I care deeply about getting my knife into something. Yep. I mean, I still want to do the surgery. But to humanize what we're trying to do here and the privilege of what we have to offer to those we serve, the What Matters to You movement has really transformed how we do that. It's now global. There are elements of the Saudi system already involved. We have an annual day. We have badges and hats and T-shirts, and it's everything you would expect from a movement. So if you haven't signed up and your system hasn't signed up for What Matters to Me, then I would suggest you do that. My second one is probably the most radical thing we did in Scotland in the last 10 years. What we did was we bought a system called Care Opinion. Now, it's a not-for-profit charity. They have no affiliation to the Scottish system. We bought it independently. We procured it. And it is, they don't like me calling it this, but in summary, it is TripAdvisor for healthcare. It is completely open, completely free, and completely unmoderated by us, by the system, feedback on every healthcare interaction. We were completely terrified. Completely terrified. We thought it would all be horror stories and how bad everything was and it isn't. It's remarkable. 70% of it is 100% positive. 70% of it. All the good stories. Now, Nick will know that as a minister, all you get are the bad stories. You only get the 10% bad stories. Those stories are still on Care Opinion. You can look right now. You can go to Care Opinion online, get the Scottish stories, and you'll find 10% of them are, I waited too long, the doctor was rude, the waiting room was dirty, all those things. 20% are mixed, like this doctor was nice, this nurse was horrible, vice versa. And 70% are completely joyous. And we now send those stories to the members of our parliament. They get the stories every month from their constituents, from their responsible region. And the feedback is given by the actual workers in the health system, not by complaints managers, not by chief executives of health systems. The nurses, the doctors, the dentists, the physiotherapists, the family physicians, they can reply in real time to the Care Opinion feedback. Again, we were terrified. We thought we would end up in fights and in courts, and that doesn't happen. Human beings have an ability to resolve those challenges. They say, I'm so sorry to hear. It's like a hotel or a airline. I'm so sorry to hear that. If you could just give me a ring, I'd love to speak to you about your dad's care, find out how we can make that better. No, it's not. Sometimes it goes bad. Of course. Sometimes it's nasty people. Sometimes people had a bad experience. The vast majority of it has opened up. We've lifted this rock and invited patients and families in a meaningful way. We were worried, but it has worked. I think it's the most radical thing Scotland's done inside person-centred care in the last 10 years. We're the only country that's bought it for the whole country. Other bits of England have it, bits of Northern Ireland have it, but Scotland bought it for the whole system. I think it's an intriguing idea to think about for a nation like Saudi Arabia.
Excellent, thank you.
I was going to say, brilliant examples. I love it. And I'd like to broaden it out slightly because, again, as senior leaders or ministers, you realize that there really aren't many levers you can pull to make change. One is money. But probably the most important one, I always believe, is actually leadership. And finding out, promoting the good people and finding out the good people in your organization. And to me, one of the best indicators I always find in terms of how good or bad a leadership is how open they are to getting that sort of information and wanting to seek that information. Yes, looking for the good, but understanding the bad and wanting to do something about it. And likewise, the people that they employ, I'm sure we've all had it, where you get some managers who, their whole team are yes people, don't like to challenge them, they don't like to promote or hire people who are going to challenge upwards to them. And to my mind, the best managers are those where if in a meeting someone else in their team shines more than anything, then I always think they're a fantastic manager because they brought someone in and they might shine brighter than them, but they have confidence in their ability to bring those people through. And that reflects so well on the manager that does that open spirit. So in terms of engendering a really good culture, I think all those points that we made hopefully are helpful.
Yeah, no, thank you. Thank you to the three of you. We've heard a lot about humanizing, you know, the encounters. Could those encounters be within, you know, your own management and leadership team? Could those be with patients or within your own clinical teams? Sometimes we forget. We're too busy. We are pulling so many different directions. We have many different needs and many tasks to complete. So we forget about the human side of our relationships that should be always, you know, in the forefront. So we're reaching the end of Forum 2025 of Model of Care. And I hope that the three of you are as impressed as I am on how the Kingdom of Saudi Arabia is moving forward with this massive healthcare transformation in such an ambitious timeline. Perhaps you want to share with us what has been the most impactful aspect of this transformation that you have heard over the past 2 days, that you congratulate our audience and everyone involved in this transformation here for.
Can I answer your question and then
Sure.
set a challenge as well? Because I don't think it's done. So the single most impressive thing as I speak to people, as I meet people, I've been on a number of visits around the country over the last 6 months. I don't know it, not even a little, but I feel as though I have more of a grasp than I had. And I think I find unique alignment around mission that I don't see in other countries.
Yes.
So there is definitely alignment around, let's call it the North Star or Vision 2030 or what's to come after that. So I think that is real, I think it's tangible, and I think it will deliver results. My challenge, though, is I think there is perhaps a gap around the quality of the delivery system and the method by which that quality will be achieved. I see conversations about the financing, which are crucial. I see conversations about the design of the delivery system, which are crucial. Remember, the Swedish, you have to do everything. I'm not suggesting we need to replace any of that. That all has to happen. But I wonder if Saudi Arabia needs somebody, something to hold the ball for quality, to say this is the most important thing. In my country, that was the ministry, and then we set up an organization at arm's length that was then responsible for that quality. Different countries do it in different ways. Some systems do it inside the delivery system. I think there's a problem with that because then it becomes nobody's job just because it's everybody's job. So I wonder if there's something. Maybe somebody will come to me and tell me that exists already, and I just haven't found it yet. Okay. That may be true. But I wonder if Saudi needs a home to drive quality and choose a method, train the workers, make sure that quality and safety are the core of everything that happens. But don't let me take away from my first point, which is the alignment of what I see.
And we heard that alignment before on a previous panel when talking about preventive medicine, right? So alignment was the answer that one of the panelists provided, and I cannot agree with you more, Professor Leach, on that alignment that is so palpable, following that North Star or whatever that star is, right? So any other comments?
Sure. I have to say, I am incredibly impressed on the alignment, the capability for an entire country to put a model of care that focuses on integration and population-based health. I personally have never seen anything like this before. An entire country positioned to create arguably the world's best healthcare system, I'm personally incredibly excited. I can't wait to follow it along. I'm sure next time I will have a lot to learn myself, and to see what possibilities are here in the near future is just mind-blowing. So I'm deeply appreciative of the opportunity to see and learn.
Thank you. And to my mind, actually, it was when I was here last time in Great Futures, and I saw the virtual hospital that being set up, and not just because the Saudis had taken something that they'd seen in the UK, which was like this, and absolutely put it like this, but the whole way it had set up actually a whole model in terms of remote diagnostics, and how really using the hospitals around the kingdom to get the scans, get the information, and send it into the centre where they had a panel of experts looking at it, and really getting the best brains looking at everything. And it was a really interesting distributed health system, which I haven't seen in the same way anywhere else. And I think we could learn tons from in the UK. I'm guessing probably everywhere.
When I went to visit them, I tried to convince them to take Scottish patients, because the patients could be anywhere. It was so impressive. I said, I'm going to send you my neonatal intensive care patients, and you can do them at Saha virtual. I'd never seen anything like it. It's literally globally changing. There is no reason why Saudi Arabia couldn't report the films for the Scottish health system. There's no technological barrier to that anymore. So I completely agree with you.
Yeah, and from someone that has actually used the virtual hospital, practicing in this country in remote areas, I can tell you that I had never been so supported anywhere else in the world when I have practiced. The alignment, I've never experienced the alignment in the front lines. The commitment, the buy-in, the drinking of the Kool-Aid that we talk about, right? It's impressive, it's palpable. The passion for the transformation, and all for the benefit of the patient and the community. We're also leaving you with the thought from Professor Leach. Perhaps that global quality and safety ownership is something that we need to start thinking about moving into model of care 2.0. Great comments. Please join me thanking the panelists for their insights. Great forum. Thank you so much, the three of you.
Amazing 2 days, discussions between the panelists, the talks, the discussions in the hallways. I think the amount of exchange of knowledge between us, the amount we learned, the amount of insights we gained throughout these 2 days was amazing. I think we have to take a couple of messages back home to go back and work on. A lot of homework for us in the model of care. First one is, please keep on giving us feedback about the system, about how you think we should do things better. And I'm speaking to either our colleagues in the clusters, other health sectors, our international colleagues and experts who have worked in so many different systems. First message for me is we should always remember the patient, the community should always be the focus of what we're doing. Everything should revolve around our beneficiaries, our patients, our communities, our families, and so on. Second thing, quality and value are very important. We have to keep on improving on what we do, going back to what we did and see if there are areas of improvement. Third is technology and using technology and anchoring technology and leveraging it to what we expect, using data properly, using AI and machine learning and so on and so forth. The other thing is our professionals on the front lines. We have to start looking, and a couple of the panelists talked about this, our healthcare professionals, how we can upskill them, how we can keep model of care in their mind, so when they practice, when they provide care, it's focused around model of care. And maybe one of the things that should make us as Saudis proud is that the new model of care is a new global standard. It's something we should talk about more. We should start talking about with other countries and other organizations. And we should focus on what we're doing to represent the country in the proper way. I want to remind you tonight at 7 is the closing ceremony. All welcome to attend. We're looking forward to having you. It's going to be interesting, and there's going to be an interesting discussion. There's a nice panel that's going to happen. And I would like to thank you for the 2 amazing days. See you guys next year.